Let us pray. Lord, we thank you, God, for this day. We thank you, Lord, being a good day. We thank you, God, as we welcome your presence here at this National Health Research Conference. We thank you, Lord, for bringing minds together. For, Lord, you said in James 1:5 that if any man lacks wisdom, he should ask for wisdom, and you give liberally. We thank you, God, as we bring the minds together, that, Lord, all the innovations, God, all the research, Lord, will be put into action in the name of Jesus. Lord, we thank you, God, for everyone present here in the room and online, Father. Lord, we pray, God, a blessing on every life, every household. Lord, that we be able to bring help to the communities that we serve. Lord, we pray that you will just guide us in a special way. We pray that you will touch, Lord, even our PS, our CMO, Lord, our minister, and Lord, all the directors and the regions, Lord, involved in bringing this together, the organizers, Lord, for this research. Lord, we pray, God, that even as we continue, as this being an important 15 years of bringing knowledge together, that, Lord, we be able to ensure that our programs be evidence-based. Lord, we thank you, God, for the wisdom that you have given us. Lord, we pronounce a blessing on this research conference and what would emanate from this research conference, Father. We say be honored and be glorified. In Jesus' precious name, amen.
Thank you, Dr. Lord. Yes, you may be seated. Ladies and gentlemen, I now yield the podium to Dr. Nadine Williams, Director, Health Systems Planning Branch, who will formally welcome you to the opening ceremony of the National Health Research Conference on behalf of the Chief Medical Officer of the Ministry of Health and Wellness, Dr. Jacqueline DeSesa McKenzie. Now, I know she is going to do the welcome, but you, please, make her feel welcome.
Good morning, everyone. Mr. Master of Ceremonies, Mr. Theodore Henry, Mr. Errol Green, our Permanent Secretary in the Ministry of Health and Wellness, Dr. Paul Edwards, Advisor, Health Systems and Services, Pan American Health Organization, who is here representing Mr. Ian Stein, PAHO WHO Country Representative for Jamaica and Bermuda and the Cayman Islands, Dr. Laura Lee Budrum, Head, Vector-Borne Diseases, CARFA, representing Dr. Lisa Indar, Ad Interim Executive Director, who is joining us online, Dr. Karen Webster, Principal Medical Officer, National Epidemiologist, Dr. Andreen Grant, Director, Epidemiology Research and Analysis, Professor Marvin Reed, Co-Chair, Essential National Health Research Committee, Dr. Shelley McFarlane, Senior Lecturer of the University of the West Indies, Dr. Sharon Dawson, Consultant Nutritionist at the Ministry of Health and Wellness, Directors in the Ministry of Health and Wellness, members of our National Health Research Conference Planning Secretariat, distinguished guests, members of the media, ladies and gentlemen, good morning. Good morning. It does give me great pleasure to welcome you on behalf of the Chief Medical Officer, Dr. Jacqueline DeSesa McKenzie, to the 15th Annual National Health Research Conference, one of the most anticipated events on the calendar of the Ministry of Health and Wellness. This conference brings together the brilliant minds of our public health professionals, all united by the shared commitment of advancing Jamaica's public health system. Our convening here and in the virtual space highlights that public health is not a solo walk. Health is truly everybody's business. It is the tapestry of our communities and environments, our minds, our bodies, our choices. The interconnectedness of these elements shapes the public health landscape in which we all graze. In the interconnected world, diseases know no boundaries, and health threats no respecter of persons, making collaboration and innovation essential to our public health strategies. Health research, therefore, plays a critical role in advancing societies through significant discoveries and new findings that support improvements in healthcare. As the world evolves into a more data-driven one, it continues to lean upon research to unlock knowledge that will help safeguard people against health and safety threats. The National Health Research provides the platform to showcase and dissect the work of Jamaica's exceptional researchers, renowned public health professionals, and experts in other fields. As the Ministry of Health and Wellness moves to strengthen its health systems, it is keen on becoming more responsive in its efforts to reduce mortality, illness, and disability among the population. Reducing mortality, morbidity, and disability due to poor quality of health care, eliminating priority communicable diseases, eliminating neglected infectious diseases, and reducing the number of cases of death, disability, and illness. These health impact goals, which we have targeted for action by 2030, can be realized with the collection and analysis of data that is representative of our population. This augurs well for the development of relevant and effective policies. This year's conference theme, Health, Everybody's Business, is a clarion call for national dialogue to share insights and leverage our collective expertise to shore up our health security and resilience. As we in the public health know all too well, there must be continuous renewal of our understanding and management of health issues to overcome health threats, respond aptly in emergencies, and improve upon the care offered, both preventative and curative. This conference is sure to offer an assortment of enriching discussions for participants and attendees alike. I congratulate the planning team and those who will have their work presented throughout the conference. I look forward to the fresh insights and new knowledge to be unearthed, with the anticipation that we will build on existing research and take note of the best practices that will redound to the benefit of our people, our communities, and our nation at large. So again, welcome to this, the 15th National Health Research Conference, and may I wish you the very best. Thank you.
Thank you, Dr. Williams, for the welcome on behalf of Dr. Jacqueline Bisesa McKenzie, our Chief Medical Officer. Dr. Williams, I just did a bit of research because we're all about evidence-based, and I realized I shortened the A in your name. It's Nadine. Am I getting that right now? Nadine Williams. And Dr. Grant, you'll extend the same forgiveness to me, I hope. I would like to underline two things that were said in your welcome. Unlock knowledge and leverage collective expertise. Feel big and important when you say it that way, don't it? It feels like a momentous occasion. And that's what I want all of us to understand. Not just an event, it's not just another conference to tick off. This truly is an effort in safeguarding Jamaica land we love from the context of health. So, I have a few announcements right here before we move forward. For those online, I would like you to know that there's something very important that you can gain here today and over the next 3 days. And I'll say that it is free because it is. The conference will offer free continuing medical education credits, mental health and ethics credits for all health and health-allied professionals. Did I say free? I did say free. You pay nothing for this. So ensure that on your registration form in your profile online, your email address is properly stated and you had clicked yes for the CME credits. And you must be logged on to the conference by the Zoom link to claim your continuing education credits. And of course, please put the email address that you regularly use because the NHRC Secretariat will contact you at that email address when your certificate is ready. We're also inviting you, both online and offline, to visit the virtual poster hall. There are some posters that have been on 21, I believe. You're invited to visit the virtual poster hall. Take a look through, leave questions and comments in the spaces that are available for you to do so. As we say in Jamaica, give the people my strength, man. Are we Jamaicans? Should I not use any more patois? Okay. Again, you log in by clicking logging on the website, putting your details, then click the posters tab to view the posters. All right, having covered that, here to bring us greetings from beyond our borders are Dr. Paul Edwards, Advisor, Health Systems and Services, on behalf of Mr. Ian Stein, am I getting that? Stein, Pan American Health Organization and World Health Organization representative. Dr. Paul Edwards, the podium is yours.
Thank you very much, Mr. Master of Ceremonies. A pleasant good morning. Mr. Errol Green, Permanent Secretary in the Ministry of Health and Wellness. Dr. Nadine Williams, Director, Health Systems, Planning and Implementation, deputizing for Dr. Jacqueline Bisasser McKenzie, who is the Chief Medical Officer. Dr. Karen Webster Kirk, Principal Medical Officer, National Epidemiologist, Ministry of Health and Wellness. Dr. Andreen Brandt, Director, Epidemiological Research and Analysis. Dr. Carol Lord, Program Development Officer, Family Health Unit, Ministry of Health and Wellness. And online, Dr. Laurelie Boudram, who is deputizing for Dr. Lisa Indar, who is the Ad Interim Executive Director for CARPHA, the Caribbean Public Health Agency. And definitely our very energetic Master of Ceremony, Mr. Theodore Henry. Chairpersons, moderators, presenters, and especially invited guests who are present here with us this morning, and also those online, and also to the media. Once again, good morning. So I'm supposed to read what is on here, and it says, I'm extremely pleased. But I want to say I'm ecstatic to be here this morning, to be at the 15th Annual National Health Research Conference, titled Health and Wellness, Everybody's Business, and also to bring you greetings on behalf of the PAHO WHO representative for Jamaica, Bermuda, and the Cayman Islands, Mr. Ian Stein, who sends his apologies this morning for not being here due to other commitments. Firstly, I truly want to commend the Ministry of Health and Wellness for organizing this conference to highlight the essential role that research plays in building resilient health systems and tackling critical health challenges. Research is indispensable for resolving public health challenges, whether it be tackling diseases of poverty, responding to the rise of chronic diseases, or ensuring that mothers have access to safe delivery practices. Likewise, shared vulnerability of global threats, such as severe acute respiratory syndrome, Ebola virus disease, Zika virus, and avian influenza, COVID-19, Mpox, has mobilized global research efforts in support of enhancing capacity for preparedness and response. Research is strengthening surveillance, rapid diagnostics, and development of vaccines and medicines. Public-private partnerships and other innovative mechanisms for research are concentrating on neglected diseases in order to stimulate the development of vaccines, drugs, and diagnostics where market forces alone are insufficient. We're all cognizant that research for health can span 5 generic areas of activity: measuring the magnitude and distribution of the health problem, understanding the diverse causes or the determinants of the problem, whether they are due to biological, behavioral, social, or environmental factors, developing solutions or interventions that will help to prevent or mitigate the problem, implementing or delivering solutions through policies and programs, and also evaluating the impact of these solutions on the level and the distribution of the problem. So PAHO's response, therefore, includes some of the following: promoting the generation and use of health policy and systems research as a means to improve the health systems and moving towards universal health. Providing information on research for health, serving policymakers, healthcare providers, the general public, and anyone interested in using research to advance public health, equity, and development. Also focusing on strengthening of research for health through the dissemination and translation of knowledge and the promotion of research governance and standards within research practices. All of us here, as stakeholders in health, understand that research is the foundation of effective public health policies and strategies. Quality research provides the evidence necessary for making informed decisions and addressing our most urgent health challenges. The recent COVID-19 pandemic has shown us just how essential research is by revealing how interconnected and vulnerable we all are to health threats. This and other health crises have demonstrated that research shouldn't just only respond to challenges. It should also strengthen our health systems, promoting us to develop life-saving vaccines, better diagnostics, and effective preparedness and response strategies. PAHO WHO fully recognizes the transformative power of research in achieving the highest possible level of health for all. This commitment is reflected in WHO research strategy, which encourages global collaboration to harness science and technology, generating evidence-based tools for improving health. PAHO's policy on research for health underscores the dedication to being knowledge-driven organization. This policy calls for sustainable national health research systems across the Americas and the Caribbean, ensuring that research evidence remains the cornerstone of our efforts to achieve health equity. PAHO WHO also believes strongly in cross-sector collaboration with public-private partnerships playing a critical role in addressing neglected diseases and developing innovative solutions where they are most needed. Through robust research mechanisms, countries in Latin America and the Caribbean, including Jamaica, have made great strides in building governance frameworks to uphold ethical standards in research. PAHO WHO promotes a systematic approach that spans all areas of research, reinforcing coordination among stakeholders to maintain a consistent commitment to ethical research. Strengthening Jamaica's health system has never been more essential, particularly as we navigate emerging and re-emerging threats and the persistent burden of chronic diseases. Collaboration between governments, the scientific community, and society is key to building health systems that are resilient, inclusive, and capable of meeting the challenges of a changing world. Over the next 3 days, as I looked at the agenda, I was very impressed as we will be exposed to different, rich, and totally pertinent thematic areas at this research conference. PAHO WHO is proud to stand with Jamaica in advancing health research and reinforcing evidence for informed decision-making. We look forward to seeing the impact of this important conference, confident that they will contribute meaningfully to the nation's health system and to bring us closer to achieving universal health and leaving no one behind. Here are wishes for a highly productive and successful conference. Thank you.
Thank you, Dr. Edwards. I too felt, although I know when you looked at the topics over the next 3 days, you were impressed from a much deeper perspective than I was. But I looked at it and I was like, this is worthwhile based on the topics alone. If I could just underline one thing from your comment. Research is the foundation of effective public health policy. Thank you for sharing that with us. Now, ladies and gentlemen, I invite you to turn your eyes to the screen of your choice. There, one on your left, one on your right. We will now be getting greetings from Dr. Laura Lee Budram on behalf of Dr. Lisa Indar, the Interim Executive Director, Caribbean Public Health Agency, CARPHA. And she'll be giving us those greetings virtually.
Good morning to all protocols previously observed. On behalf of Dr. Lisa Indar, Interim Executive Director of the Caribbean Public Health Agency, I'm pleased to bring welcoming remarks and extend our sincere congratulations to the Ministry of Health and Wellness Jamaica on the hosting of its 15th Annual National Health Research Conference. CARPHA remains fully supportive of the scientific forum that allows for the sharing of current and innovative health sector research, which fosters the development of evidence-based policies, practices, and programs. This year's conference theme centers around a key pillar in these current times: health and wellness, everybody's business. The World Health Organization, its constitution states that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It is no surprise that in our fast-paced, interconnected world, the well-being of each individual is intricately linked to the health of our communities, our economies, and our environment. It is an essential truth that health is indeed the business of all. It speaks to the right of people everywhere to have access to quality healthcare services, education and information, clean air and water, good nutrition, quality housing, as well as safe working and environmental conditions. However, to achieve the aforementioned, collective action is needed, otherwise the success of this initiative will become ever more elusive. Participation from all sectors is imperative, whether we are speaking of the government, the private sector, non-governmental organizations, healthcare providers, and individuals alike. When we look at recent global and international health crises, such as the COVID-19 pandemic, the continued spread of mpox, vector-borne diseases, and very importantly, the impacts of climate change on health, all of these health emergencies have underscored the importance of a whole-of-society approach. what affects one can in turn affect all. These issues have highlighted the need for robust public health systems, community engagement and support, regional and international cooperation to address these challenges that transcend all our borders. During this year's conference, researchers will present abstracts under 5 main thematic areas that will not only feature local health initiatives, but also advocate for policies that promote health equity. These include presentations on workplace health and wellness, factors associated with healthcare delivery, violence and injuries in vulnerable groups, technology in health, and climate change and health. Health does not exist in isolation, and let us remember that health is a shared responsibility. It is not solely the duty of healthcare professionals or policymakers. It's a commitment that we must all embrace. By working together across disciplines, sectors, communities, and borders, we can cultivate a healthier future for everyone. Our very best to the Ministry of Health and Wellness on the successful hosting of this conference. We hope that the knowledge received and disseminated by participants will spur new inspiration, partnerships, and collaborations within and external to the health sector, and contribute to healthy people, healthy environments, and a healthier Caribbean. Thank you.
Thank you, Dr. Budram. Holistic health, holistic participation, underpinned by research and policy. The thrust of your greetings there to us. At the beginning of the conference, I mentioned that we had X amount of oral presentations and Y amount of poster presentations. You guys remember the numbers? How many? 21 posters. You're asking me or you're telling me? You're telling me? Oh, I love it. What about the oral presentations? Anybody remember? How many we have? More than one. Give that man no prize. All right, I'm hearing the answer, you know, but I'm not hearing the confidence. 26 oral presentations and 21 poster presentations, and they are vying for the prizes on offer. Now, what are these prizes? Let me tell you. Now, of course, we'll have the titles themselves, which will be Best Overall Presentation, Most Impactful Oral Presentation, Best Student Oral Presentation. Yes, happy to have the students among us. Best Overall Poster Presentation, Most Impactful Poster Presentation, and of course, again, Best Student Poster Presentation. Now, those are the prizes you're vying for. Of course, all those titles, along with the professional boost, along with the trophy and the plaques that you'll get, all of those titles are on offer. However, let me hasten to say at this point that it is more than just the prizes. It's more than just the professional boost. It's more than just the trophies and the titles which you will gain. Researchers, your work will inform public health policy, national public health policy, right? And this is a stated core objective of the NHRC, and that is to identify operational research with the potential to influence or be translated into policy. What you discover, what you bring forward, can become public policy. It truly is a holistic effort on behalf of our professionals. And you'll find more details on all of this in your conference booklet, which will be available on the website. Now, we're going to mix things up a little bit at this point. We're going to introduce a little music into the mix. Now, please help me welcome Miss Kimela Candy Isaacs. Sing. Hold on. Let me give you a reason to clap. Singer, songwriter, vocal coach, music director, and get ready to clap, winner of the 2024 Jamaica Festival Song Competition. Now you clap.
Good morning, everyone. All right, let's do this again. Good morning, everyone. It's a pleasure for me to be here to encourage your hearts this morning. To be, being a part of this conference, I consider it an honor. It's good to see your lovely faces. Being your VIP, visually impaired professional. Let's go. Birds flying high, you know how I feel. Some volume, please. Sun in the sky, you know how I feel. Breeze drifting on by, you know how I feel. It's a new dawn. It's a new day. It's a new life for me. And I'm feeling good. Fish in the sea, you know how I feel. River running free, you know how I feel. Blossom on a tree, you know how I feel. It's a new dawn, it's a new day, it's a new life for me. And I'm feeling good. Dragon flies out in the sun. You know what I mean, don't you know? Butterflies all having fun. You know what I mean. Sleep in peace when day is done. That's what I mean. And this old world, it's a new world, and it's a bold world for me. It's all for me. Woo! I'm feeling good. You know that I would now. I feel good. You know that I would. So good, so good, so good. Stars when they shine, you know how I feel. Scent of the pine, you know how I feel. Freedom is all mine. That's how I feel. It's a new dawn. It's a new day. It's a new life. It's a new dawn. It's a new day. It's a new life. It's a new dawn. It's a new day. It's a new life for me. And I'm feeling good. Health and wealth is everyone's business. I'm feeling good, 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 good. I feel good. I'm feeling good. I'm feeling good. Thank you. So I was introduced as the festival song winner for 2024. I'll be doing the festival song for you just now. Health and wealth is everyone's business. That's because we are one Jamaica. Everybody say one Jamaica. Never two. One Jamaica, never two. That is it. All right, let's go. We've come a long way, standing in a strong way. One Jamaica, one Ministry of Health. God's mercy is near, is like a breath of fresh air. So let's send up some praise and thanksgiving in the atmosphere. Are you ready? We've come a long way, standing in a strong way. We never give up on God, cause Him not give up on we. Out of many, we are one nation, one family. We activate rising faith and joyfully celebrate one Jamaica. This sweet Jamaica where we born and grow, attracting tourists all over globe. We never grow dim, we will always shine, displaying pure love from the true divine. Yes, we have problems we can solve as we keep looking to the Lord above. One Jamaica, one blessed island, protected by Jehovah's mighty hand. So make we run with the negative, and then we run with the positive. Sing praises to Jah each day, whose mercies extend our way. This is a good place of birth. We're like a paradise here on earth. One love, one day. We've come a long way. We've come a long way. Standing in a strong wake up. We never give up on God, cause Him not give up on we. Out of many, we are one nation, one family. We activate rising faith and joyfully celebrate one Jamaica. Jamaica moving to the top now, and we're never gonna stop now. We determined on the track and field, with the golden trend that's signed and sealed. Sweet reggae music is the vibe for real, expressing true Jamaican music meal. Cause we are one Jamaica, one blessed country. Our hearts salute, triumphant, proud and free. So make we fun with the negative and fun with the positive. Sing praises to Jah each day, whose mercies extend our way. It's a good place of birth. We're like a paradise here on earth. One love, one day. We've come a long way. We've come a long way. Standing in a very strong wake up. We never give up on God, cause Him not give up on we. Out of many, we are one nation, one family. We activate rising faith and joyfully celebrate one Jamaica. We've come a long way. We've come a long way. Standing in a chum wake up. We never give up on God, cause Him not give up on we. Out of many, we are one nation, one family. We activate rising faith and joyfully celebrate one Jamaica. So let we run with the negative and run with the positive. Sing praises to Jah each day, whose mercies extend our way. It's a truly good place of birth. We're like a paradise here on earth. One love, one day. Hey, one love, one day. Hey, one love, one day. Hey, one love, one day. One love, one day. One Jamaica, never two. God bless you.
All the applause you have in you. I thought this space right in front here was left specifically so that we could dance. I mean, so nobody get up and dance. So, you know, the peer pressure kept me in my seat. But that's all right. Those were move your body worthy songs. And we really appreciate that music, adding the music to this ceremony. Let me pause a moment and acknowledge the presence of Dr. Jacqueline Bisesa McKenzie, our Chief Medical Officer. Now, here with us at the conference hub today on my right, yes, my right, your left, is Mr. Errol Green, Permanent Secretary in the Ministry of Health and Wellness. And he brings to that substantive post quite a bit of experience. Prior to assuming his current role, Mr. Green previously served in the public health sector as the regional director of the largest health authority. Anybody knows which one that is? Confidence, Southeast Regional Health Authority. I've always called it Sarah, but is it Sarah or Sarah? Sarah? All right, that's what you says. Mr. Green, is it Sarah or Sarah? Whatever I choose, I'll work with that. So, to Mr. Green falls the moment and the podium to deliver not another song, but this morning's feature address. Mr. Green.
Thank you very much, Mr. Master of Ceremonies. I don't know, Stephen, where you got this one from. Are you an employee of the Ministry of Health? Well, we need to recruit you in some position. But good morning, ladies and gentlemen. Mr. Master of Ceremonies, Mr. Henry, Dr. Jacqueline Bisesa McKenzie, Chief Medical Officer, Dr. Nadine Williams, who so ably represented you in your absence, Dr. Paul Edwards, Advisor, Health System and Services, PAHO, Dr. Laura Lee Budram, representative from CARFA, Dr. Karen Webster Carr, Principal Medical Officer, Ministry of Health and Wellness, Dr. Andreen Grant, Director, Epidemiological Research and Analysis, Ministry of Health and Wellness, other executives of the ministry and the regional health authorities, researchers, members of the media, our colleagues online, ladies and gentlemen, good morning. I stand here this morning representing our Honorable Minister of Health, who could not be here this morning, and I was given the privilege and the honor to speak the words that were prepared for him to deliver this morning. And so I start. It is an honor to address you at the 15th National Health Research Conference, an event that brings together some of the brightest minds in health and wellness to explore solutions to the pressing challenges facing our nation and the global community. I first want to commend the epidemiology unit on this conference. The team's committed effort displays that of a consistent contribution to the body of health literature to inform the development of health policies and continuously improve healthcare service delivery. Research is the cornerstone of innovation, the pathway to understanding complex health issues, and the driving force behind policies that improve the lives of our citizens. The work presented at this conference yearly serves as a reminder of the transformative power of evidence-based approaches in shaping a healthier and more equitable future. As we gather here, it is important to recognize the progress we have made in addressing public health challenges, from improving maternal and child health to combating non-communicable diseases and responding to emerging pandemics. Health research has played an integral role in guiding our strategies and shaping our intervention. Yet, as we celebrate our achievements, we must also remain vigilant in addressing persistent health disparities and preparing for future challenges. The Ministry of Health and Wellness is deeply committed to advancing health research as a tool for national development. We understand that reliable data and robust evidence are essential for creating effective health policies and ensuring the optimal allocation of resources. How do we address the growing burden of non-communicable diseases in our population? What are the most effective ways to strengthen our healthcare system's resilience in the face of pandemics or natural disasters? How can we leverage technology and innovation to make healthcare more accessible to rural and underserved communities? By fostering a culture of inquiry and evidence, we can identify solutions that are not only innovative, but sustainable and inclusive. One of the most exciting aspects of this conference is the spirit of collaboration it inspires. Health challenges are complex and multifaceted, requiring interdisciplinary approaches and partnerships across sectors. Whether it is academia working alongside government agencies or community organizations joining forces with international bodies, it is only through the collective action that we can achieve meaningful impact. I encourage you all to continue building bridges, sharing knowledge, and working together toward a common goal, a healthier Jamaica for all. Ladies and gentlemen, let us not forget the power of research to inspire action and to drive change. Each paper presented, every discussion held, and all the insights shared at this conference have the potential to shape how we approach healthcare in Jamaica. The ministry stands ready to support initiatives and translate research findings into tangible outcomes, from improving patient care to developing public health campaigns that resonate with our communities. Distinguished colleagues, I want to reaffirm our commitment to fostering an environment that values and supports research. We will continue to invest in the development of researchers, provide platforms for disseminating knowledge, and advocate for the integration of evidence-based practices into all levels of healthcare delivery. In closing, I commend each of you for your dedication to advancing health research. Your work inspires hope and presents the very essence of what it means to strive for a healthier, stronger nation. Together, let us ensure that the insights gained here today will drive impactful actions for the betterment of our people. And your theme for this research conference is very instructive: health and wellness, everybody's business. On behalf of our Honorable Minister of Health and Wellness, Dr. Christopher Tufton, I thank you, and I wish you all a productive and inspiring conference. Thank you.
Thank you, Mr. Green. I appreciate the highlight you placed on the successes so far. Not just the need in going forward, but the fact that we have been successful through evidence-based, through research going forward so far. And if I may echo what you said, near your end, researchers, your work inspires hope. Thank you, Mr. Green. Now, ladies and gentlemen, you know how certain organisms have different ages based on what they are. I didn't say that well, so let me try that again. A 15-year-old human is different from a 15-year-old cat, don't it? And a 15-year-old cat is different from a 15-year-old dog, don't it? So while a 15-year-old human is a teenager, a 15-year-old event is a big deal. That's big and mature and proper. To stay and hold the course for 15 years is not a small task. And I know the planners of the National Health Research Conference can tell you that it's been a big deal to keep it going for 15 years. You applauded for this. Somebody said amen. All right, all right. And so at this point in the opening ceremony, we are going to have two significant things happening right now. One is a plaque ceremony, and the other is a ceremonial cake cutting ceremony. So, Mr. Green, I know you just took your seat, but I need you again. We're going to start with the plaque ceremony, Ms. Mullings, I believe, and I'm going to invite Dr. Bisesa Mackenzie alongside Permanent Secretary Green, NHRC members, Dr. Karen Webster-Carr, Dr. Andreen Grant, Dr. Shelley McFarlane, Dr. Stephanie Bernard-Stevens, and Dr. Sharon Dawson to approach the stage and be appropriately placed by Sir Stephen as we carry out this plaque ceremony. We're going to get there, man. We're going to get there. But first things first. And as we arrange ourselves, I don't know if we have a little music that we could underpin the arrangement with as those online watch the ceremony take shape. For those who are online and those who are as old as I am and need to be real close, let me tell you what the plaque says. The title of the conference is on the plaque, proclaiming the fact that it is 15 years. And this is a commemorative plaque in a beautiful blue, celebrating 15 whole years of national health research. All right. You saw the plaque. You saw the plaque, and it's a beautiful plaque. Now, I was asked about the cake eating ceremony, but good sir, I only have cake cutting on my list. But Dr. Bisesa Mackenzie is at your desk, at your table, so you can take that up with her. Permanent Secretary Green, don't sit yet. Dr. Bisesa Mackenzie, we need you one more time. Dr. Webster-Carr and Dr. Grant, we're inviting you to approach the table for the cake cutting ceremony. And you get the plate. Eh? If a cake is cut, it should be eaten, don't it? That's right, that's right. Right, the knives are being presented. And as we get ready to cut the... Oh, I'm counting. I feel like we should go from 15. No, too much? All right, after 3 then. After 3. 1, 2, 3. A round of applause, a round of applause. Now, let me hasten to say that those who were participating in the plaque ceremony are members of the planning committee from day 1. They have committed 15 years of their expertise, of their time to this event. And I will allow the powers that be to dictate what happens to the cake now that it has been cut. Thank you, ladies and gentlemen. And with that, as our leaders take their seats, the 15th staging of the National Health Research Conference is now officially open. And conversely, our opening ceremony is now officially closed. As we delve into the fascinating themes to be covered over the next 3 days, those online, those in person who are also able to go online, don't forget to leave your feedback about the conference by rating the sessions and completing the conference evaluation form. You will see that on the website. It should be in your profile panel as well. Also, we are encouraging, inviting, sort of pressuring you to take part in the activities on the website. Get your points, get your name up on the leaderboard. There are prizes that accompany that as well. Also, don't forget, as soon as it's available, to get a copy of the conference booklet. It's been 15 years, which means there have been 15 sets of winners. There's a special feature in the booklet called Where Are They Now? All right, where you can track what the winners have done, where they have gone, the heights they have reached in their professional careers post-conference. I'd also like to extend thanks. Thanks to all those present, our leaders, directors that are previously acknowledged, those in attendance at the conference hub. Thanks to our researchers who have made submissions, or attendees online. Thank you. Thank you to all those who contributed to the success of this opening ceremony. And I'd like to acknowledge 2 people in particular. Now, you may have seen, right? Let me get the pointing. There. Yes, I've got it right. That is Miss Antoinette Aiken. And she's been delivering professional sign language for us. And I'd like you also to reserve some applause for our technical team. To those who delivered speeches, to those who sang, to the planners, and to everyone for their presence, thank you so much for being here this morning. I invite you all, participants and attendees, to immerse yourself in the content and enjoy the next 3 days of explorative excellence. It has been my pleasure to be your Master of Ceremonies. My name is Theodore Henry. Good day.
What you done? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm there in the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are going to drop.
No, go so. At 5 I want me breastfeed.
I'm not in my breast then.
No make nobody stress you out. Because if you're stressed, you never produce enough milk. I better ask your nurse or your doctor. You hear the matter about breastfeeding support in the clinic. They teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to you.
I don't need further to go clinic.
And make sure you ask for the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
I was first diagnosed with cervical cancer. The treatment was not pretty. It was terrible. I couldn't work. And I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought I'm finished with cancer. 2016, cancer come back. There is hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
If you know one pop down and get, if you burn mosquito and run with it, so don't make water circle in open container. For them to read up under the danger. Usher them out, run them away. Send them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household now, make them come in. If you know one pop down and get, if you burn mosquito and run with it. A message from the Ministry of Health.
COVID is stress-free. Don't take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir? Me. Stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vox up, me stop fret.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back to life.
Zoom in on the nutrition facts. If they in the table by the side of the back, you can check out the
Get back to life.
Zoom in on the nutrition facts. If they in the table by the side or the back, you fi check out the servings. Just do the maths, not taking too much. Finger below the facts. Zoom in on the nutrition facts. If they in the table by the side or the back, take note of the sodium, the sugars, and the fats by percentile. Let's end up on the right track. You fi zoom in on the nutrition facts. If they in the table by the side or the back, vitamins, minerals, and vitamin 20% and more that good for you. You fi zoom in. Check the nutrition facts. You feel check the nutrition facts. You feel check the nutrition facts. Less sugar, less salt intake, and less fat. You feel
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the National Health.
Zoom in on the nutrition facts. If they in the table by the side or the back, you fi check out the servings. Just do the maths, not taking too much. Finger below the facts. Zoom in on the nutrition facts. If they in the table by the side or the back, take note of the sodium, the sugars, and the fats by percentile. Let's end up on the right track. You fi zoom in on the nutrition facts. If they in the table by the side or the back, vitamins, minerals, and vitamin 20% and more that good for you. You fi zoom in. Check the nutrition facts. You feel zoom in. Check the nutrition facts. You feel zoom in. Check the nutrition facts. Less sugar, less salt intake, and less fat. You feel zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the National Health Fund, and JAPNet.
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in the hospital.
So why you never tell me?
Me didn't even know. Me not rest. A peer problem with breastfeeding. People keep on telling me something for the baby bush tea and say it good for him. Then my friend them a tell me say if my breastfeed, my breast a go drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not gonna produce enough milk. I better ask your nurse or your doctor. Me hear the matter about breastfeeding support with our clinic. Then teach the young mothers how to breastfeed properly and take care of the picnic. Then teach our family to,
They're gonna eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work. And I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for you, your sake, and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message.
So no make water circle in open container. For them to read up under the danger. Usher them out, run them away. Zap them with the zapper and down them with spray. Use mosquito net and mosquito screen. Protect your household, now make them come in. If you don't want pop down and fenke. If you burn mosquito and run with dengue.
A message from the Ministry of Health.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir? Me, stop for it because my vax up.
I made sure my mom and I got done is key.
Me, vox up, me stop for it.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back to life.
Zoom in on the nutrition facts. It there in the table on the side of the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It there in the table on the side of the back. Take note of the sodium, the sugars and the fats. 5% or less in on the right track. You fi zoom in on the nutrition facts. It there in the table on the side of the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the National Health Fund, and JAPNet.
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when my day in the hospital.
So why you never tell me?
Me didn't even know. Me not rest. A peer problem with breastfeeding. People keep on telling me something for the baby bush tea and say it good for him. Then my friend them a tell me say if my breastfeed, my breast are gonna drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you stress, you're not gonna produce enough milk. I better ask your nurse or your doctor. Me hear the matter about breastfeeding support with the clinic. Then teach the young mothers how to breastfeed properly. And take care of the picnic. Then teach our family to, you know.
They're gonna eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
Initiative in the emergency departments that have seen improvement in patient flow in the emergency department and an increased capacity at health centers. Let us welcome Dr. Bisesa Mackenzie.
Thank you, Dr. Webster-Carr, and morning, everyone. Stephen, you need to update that profile from 10 years ago, since I've been at the ministry for 10 years now. All right. Really want to congratulate the team on 15 years of excellence, and it grows stronger and stronger each year. And even though, it is a small, in-person team, I really must say that, the energy that you can feel here, I hope it is translated to the persons that are online, because in my mind, this is a very vibrant conference already. So I really want to thank the organizers. I was asked to speak on continuum of care, integrated healthcare delivery. Oh. It's shared. Where is it shared? It's not on there. Oh, okay. All right. Okay, good. Right. And I chose to put these hands here because, when I think of continuum of care, I think of everything joined up and connected, whether it is the care of the patient, whether it is the health services. And I wasn't able to put a heart into the picture, but I really must say that this is where my hands and my heart have been over the last couple of years, trying to work towards having, us in Jamaica having a health system that really provides a continuum of care for all our clients. So in speaking about the topic, first I have to say something about integrated health care delivery. And integrated healthcare delivery is a collaborative approach to patient care that takes into consideration the physical, mental, and financial aspects of healthcare. And when I say mental here, I'm not referring to mental health. The brain sits on top and it connects everything, organizes everything. It is the thought process. And that's where when I say physical, mental, and financial aspects of healthcare, it's really about how it is that we bring everything together, think it through properly, make sure our processes are connected. Because the goal is to provide seamless, continuous care for clients throughout their life, not just from diagnosis to treatment and follow-up care, but also for educating them to help them to make the right health choices and preventing disease. Integrated healthcare delivery utilizes many approaches, including integrated delivery systems, which is a network of healthcare providers that work together to provide a full range of services. And this can include hospitals, health centers, other health facilities, private and public, and various healthcare providers. We speak about horizontal integration, and here we're talking about organizations at the same level of care that are grouped together under one governance to form a network. And we talk about vertical integration, where we have organizations at different levels that are grouped under one governance system. And we're well acquainted with that within our public health system, where we see the different levels of care in terms of we have our primary healthcare system, and we have our secondary healthcare system, and we have our vertical integration where it is that they connect to one another. Primary healthcare is about integrated health services network at this level makes several of the essential components of a health system a reality, such as universal coverage and access, the first level of care being comprehensive, that there is continuity of care, there's appropriate quality care, and there's optimal organization and management, family and community orientation, and intersectoral action. Okay, so my next slide speaks a little bit about fragmentation. And when I hear the word fragmentation, I immediately comes to mind a bit of disorder, things all over the place, things broken down, in fragments, in tatters. That is what automatically comes to my mind. But that's not really what I'm talking about here when we talk about a fragmented healthcare service, because you can have pretty good healthcare service, but it is still fragmented. It is talking about the lack of connection, different pieces all over the place. And because, of course, the pieces are not connected, then it affects the overall performance of the health system. But it's not necessarily to say that it is, in pieces and tattered and, disordered, but it's just that it is not connected. And, I always go back to the days when we were developing the 10-year strategic plan, and persons, in the room would talk about, we have a fragmented health system. And I always thought to myself, what's fragmented about it, We have a health system, we have a primary care system, we have secondary care system, we're connected by a referral process. So in my mind, it really wasn't fragmented. But, over time, I've come to appreciate what it means by us not really being connected. I would say over the last 6 weeks, I've visited about 20 health centers. And even though it's the same primary care system, every health center I've been to are doing things differently. It's just everybody, same uniform. The public health nurses are in their brown uniform. The PCAs are in their blue uniform. And, the health promotion persons are in their gray uniform. So it looks good, But every health center, despite the fact that all of those health centers were in one region, were doing things different, And this is the part of when we talk about fragmented health system, it's not, and because you're doing things differently, that connection, that cohesiveness, even in the way we interpret data. We can't interpret data coming from different centers because they don't mean the same thing. And this is when we talk about fragmented. This is what we're referring to. A system that is not cohesive and it is not connected up. And as I said, this is a major cause of poor performance of health services and the underperformance of our health systems in general. Fragmentation can generate on its own or combined with other factors, difficulties in access to service, delivery of services of poor technical quality, irrational and inefficient use of available resources, unnecessary increases in production costs, and low user satisfaction. And it's one of the reasons why we have our patients, we can't even track our patients because they get one service at this health center because that one offers it nicely. They go to another one to get another service because that one treats you better for that service. So they're all over the place. We really can't say what is happening sometimes. So therefore, in terms of when we look at our primary health care reform and our new secondary care model, where it is that we want to go. If we're going to talk about integrated health care services and an integrated health service delivery, first thing we have to do is to look at what is our model of care. And we have to define that, what it is that we are going to offer. And the primary health care reform is about defining that care, defining that model. What have we done? It seeks to reorient the health system, which is one of our major goals, to reorient the health system to a client care approach rather than focusing on disease. We are advancing in terms of our use. We're going to be using a life stage approach to health promotion and prevention to reorient our healthcare workers and to educate clients on their health needs and prevention. So this is one of the major things that we are working on to develop, where it is that we are going to be retraining our healthcare workers to look at the patient as a whole based on their life stage and to ensure that at each visit that there are certain health education messages that are pertinent to their life stage and certain screening that is done or offered to them. When I think about it, we have over 1 million touch points with clients every year. And yet we still have a population that don't know about many things in health, many basic things that they should know about their health. And I think that's a travesty. I think it's a travesty that we have this opportunity to connect with our clients, and yet when they come in, all we see is the rash or the swollen tonsil or the cut on the foot or whatever, and we don't see the whole picture. So that is one of our major thrusts in terms of where we're going with reform. Now, we all have spoken about epidemiological profile and the demographic profile of Jamaica, and this has changed. And so we are reorienting the system to focus on the prevention of lifestyle diseases. Point is that no area of Jamaica is spared, and our interventions must reach all our population. So, as we said, there's mentally, there's physically. We will need to upgrade strategically placed health centers to provide consistently and reliably a set of services based on the level of health center and to ensure that the referral and outreach processes are in place for the continuum of care to be maintained. So essentially a part of the reform is that we are moving to the model of our community, district, and comprehensive health centers. We are identifying, documenting what are the services to be provided at these different levels of health centers. And we are equipping the health centers in terms of resources, both human resources and infrastructure resources, and putting the processes in place to allow them to deliver that care consistently, reliably, so that our clients will know that if they go to X health center, this is what they're going to receive. You know, we don't want them to go to the health center, find out that it's not offered here, and you really have to go somewhere else, or you have to come back on whatever day. We want to be reliable and consistent in what it is that we offer. We're also expanding our services so that there's a network of health facilities that offers health promotion, disease prevention, diagnosis, treatment, disease management, rehabilitation, and palliative care, and that integrates programs targeting specific diseases, risk, and population, as well as personal and public health services. So we're expanding services in terms of adding on the rehabilitative and palliative component. In our family health unit, we are working on developing our elderly health program, our men's program, women's program. We have already been working on the adolescent health program. So we want to ensure that the service that we offer will be able, from antenatal care straight to rehabilitation, palliation, we are able to provide that service within the public system. So we've started to work on some of these things already. We have been assessing some of our health facilities, identifying the upgrades that need to be done. We are all familiar with the IDB EU project, that is upgrading 10 of our health centers, and we're using the model from the reform in terms of what those health centers are to provide. So we're making sure that they are purpose-built to deliver the services that they need to offer. And we have been looking at our community health centers and ensuring that they are able to offer services every day of the week so that there's enough space that you can run your curative clinics, your maternal and child health clinics, all your clinics at the same time. Okay. So we're also doing our workforce assessments to ensure that there's capacity to provide a reliable service. And everybody, I think, has been involved in these discussions, where it is that Dr. Reed Jones has been leading on this in meeting with all the different groups within primary health care to look at the workforce to ensure that, one, there's uniformity of service at each level of care and that everybody is clear. If it is that a nutritionist comes into the system, they should be very clear as to what it is that they're to offer at this level of care. You know, that is what we want. We don't want a guess or it is a person, very subjective kind of care. We want the population to be able to rely on us to provide the service. And so this detailed examination of the workforce is being carried out. We already know that we have gotten approval for the physician workforce, and we're hoping that the other workforces, we will take them to Ministry of Finance and to Cabinet for their approvals to be done. I'm out of time, so I'm going to try and skip through. Okay. Okay, so of course we all need to be on the same page where this is concerned, and we have not started to go out to the public to speak about the changes as yet, because we want to ensure that the healthcare workers are first of all aware of what is going on. And so we're developing training modules for the physicians and the other healthcare workers, and we are going to be delivering those first and trying to get the service prepared to deliver the service before we go to the population and say this is what you expect. But of course, you know that there's always a rush to, and we have to be very careful, especially, you know, our minister wants to have these things put in place urgently, and so we're rushing to try to keep up with him because he's very passionate about the primary health care reform as well, and to ensure that the service is being offered. Okay, organization and management. I put this picture here because it's a very nice picture. You know, I really love this picture. And you know what I love about it? The plants. The plants in the ministers' conference room at this time were at their most beautiful. Nothing else. It's the plants, okay? All right, so, but organization and management are integral. And we have to develop the policies and to make sure that all the areas are covered from the national level, and then to have, and that has to be a collaborative approach in terms of how it is that we look at the organization structures within each area. And part of what Dr. Reed Jones has been doing is that meeting with the different teams, looking at the organization and looking at the things that we are going to be implementing with a collaborative approach. Sufficient competent and committed human resources for health is going to be a problem for us. And so at the same time that we're looking at the workforce, we're looking at the training, what it is that is needed to ensure that we have persons trained, and then what it is that once they're trained, that we can keep them here. Because, of course, I can tell you that, I mean, we have difficulty opening some of our health centers to 5 days per week simply because we don't have the nurse to be able to be at the health center consistently for 5 days. So it is a challenge. And we have, I think the ministry has launched the Barry Wynn Scholarship, and I think that is very promising, and we should be congratulated for it. I think it's a very good input into the human resources for health. Now, an integrated information system that links all network members is key. And again, through the IDB project, we have been developing the pilot for the electronic health record system that we're going to be rolling out in 13 facilities. After this pilot, it is our intention, after the assessment is done, that we will roll out into further facilities. We're looking at other electronic health systems for Class 1 notification. We have the environmental health information system. We have the immunization registry that we are developing. So there is that intention that we will have that integrated information system network, because one of the failures of the implementation of the primary care perspective in the 1970s was that feedback in terms of data, that lack of a proper information systems would have prevented the system from being very responsive to the changes that would have been happening out in the field. Results-based management is very important, and every workforce that we're looking at, I'm asking, what is the M&E that we're putting in place to say that if we have this workforce and these are the things that we are supposed to deliver, how are we going to be ensuring that we are delivering these things? Now, financial allocation. I think that the government has been very good to us in health. And we have gotten approval for both at the cabinet level for the secondary care model and the primary health care reform. And we have gotten approval from the Ministry of Finance in terms of the physician workforce. So I think it also, when you look at the infrastructure build out that has been happening, we really, I have to keep saying people that it's not that we are going to transform, we are transforming. 10 years ago, I was in hospital in the emergency room, and I can tell you that I can see the difference from what it was 10 years ago. So I know that people still have a lot of complaints, and there will always be something to complain about, okay? And some of these are really things that need to be fixed. But the transformation is happening, and I believe that we all should be happy to be in our positions at this time to see that change that is happening. I am very, very grateful to be here at this time to help to channel this change that is happening in our health system. Because, I keep telling people that I want my children who are doctors to stop complaining. I want them to work in the health system and be proud of what it is that we have to offer, and just to be proud to be part of the system. And I think probably as Chief Medical Officer, I'm going to consider all the doctors my children, and to say that I want everybody to be really pleased and proud, all the healthcare workers, all our nurses, or nutritionists, or physiotherapists, or medical records persons, or everyone. I want us all to be proud of the system that we work in. And my tagline now is, let us build back confidence and pride in our health services. It is ours, and it is what we offer to the population every day we go to work. So let us have pride in it. Thank you.
Thank you, CMO, for your presentation. Well said. We feel your passion, and I think your passion has been making a difference in the transforming of the health system. So it's not just words, it's action and results. So thank you very much, CMO. We will, if there are any burning questions at this time, there's one online, so two online. Is there any in-person question? So, Dr. Alonge, or she has?
Thank you. Testing. Good morning, CMO. So much for that excellent presentation. It is really appreciated while you were presenting. I was taking notes as well. And something that came to mind, that at the time when the patient goes to the clinic and they're waiting, there's always a long waiting time. If we could utilize that timing while they are waiting to be educated about the health issues that we know they need to be aware of, that in itself give them more useful time spent while waiting to be attended to the knowledge. And then we should also add to the fact that we're going to share knowledge with them, information, maybe pamphlets, things that they can go home with and simple to understand, because sometimes the terminologies that are being used, they might not understand, so we kind of bring it to a level that every layman will be able to understand that information. So it's an excellent way to go educating the population. That is good. I appreciate the integration, the networking, and to enhance people's learning and the services. But the question I want to ask, will it be possible for incorporating within this teaching and learning the doctors who see the patient to have that room and space for questions? They would have waited for 3 hours, and when they go to the doctor, 5 minutes, they are out.
Yeah. Okay, so, and I'm glad that is not still up, but okay, so this is part of the infrastructure assessment that we're doing, because we have recognized that some health centers, even though we may want to move from 1 day of week for curative services or treatment services, it's the one consultation room that serves the maternal and child health, that serves the doctor or family nurse practitioner that comes in, that the nutritionist has to use, mental health team has to use, etc. So that is when I say we are making our infrastructure purpose-built. We are defining, first of all, the services that we want to offer, and we're making sure that the spaces are there to offer those services. So over the last, I said, 6 weeks, we are doing a consultancy, getting a consultant on board to do that infrastructure assessment, but we couldn't wait. So the team within the CMO's office, we went out and we did our assessments for what were to be the community health centers within Southern Region. And, we see where this extra space is needed. Thankfully, I think that we have NHT has come on board. We have not finalized all the details as yet, but the drawings already for some of the parishes, the parish managers have provided the drawings for that expansion, and we are getting that dossier ready to go to funding to have those implemented. And so that is what I'm saying in terms of ensuring that when we say we're, the model of care must identify what the services that are to be provided are. And in identifying those services and documenting those services for everybody to be able to see, that we have a commitment that we must provide the infrastructure and resources that are needed to be able to provide that service. So yes, we are looking at that. It is a 10-year period, so not everything is going to happen.
Thank you.
Thanks. So we'll take the two questions. Can you read the two questions, and then CMO will respond, and then we'll close off this session.
Okay, good morning. One of the questions are, have you considered training health coaches to support the patients in the clinic?
Let's do the next one.
And the next question is, have you considered providing psychologists for NC?
Okay. So for the coaches, in terms of the implementation of this life stage approach to health promotion and prevention, we have in utilizing the funds from the Global Fund, we have asked for a cadre of persons that we call LSA champions that are going to be part of that the engagement while persons are in the waiting area, as you said, and helping persons to read the pamphlets, read the information that is there. I'm not sure if that is what you mean by coaches, because coaches could be something that is more asking for a lot more. But we are, under the IDB project, working out the details of the implementation of a chronic care model that is going to be looking at targeted interventions in a population of persons that are enrolled in this model, so that we can provide them with the services, the extra things that they need in terms of that support, both support from the healthcare providers within the healthcare facility, support from within their families to increase the capacity of the families to offer that support, support from within their communities to be able to provide that environment for them to be able to manage their disorders. So there is some element of coaching in all of that. I mean, as I said, the definition of coaching for different persons can mean different things, but there's some aspects of that is included there. In terms of psychologists, we are looking at the work for the microplans that we're looking at are looking at all the different groups of workers. Now, how it is that some groups are going to be deployed across interventions for different diseases and not necessarily specifically assigned to NCD psychologists. That kind. We may not have the resources to be able to do that, but the chronic care model should be able to identify where it is that specific interventions are needed. And what we're hoping is that we will have the cadre of staff on board to be able to provide that intervention.
Okay, thank you very much.
PMO, I will just share this with you.
No.
Somebody said online, this is a comment for you, commendable. He said, the picture that you shared, not only the plan that is beautiful, that you are beautiful and your team members, and that you are appreciated and they love it as well. And somebody also suggested that for the coaching, the teaching, you can also include video while they wait, video through television. So the online persons are listening. That means they are participating, and we are doing these two modalities. So we must applaud those online. Thank you.
Thank you so much. Thank you, everyone.
Thank you, CMO. And we move on to the next. Thank you.
Good morning and welcome. I am Dr. Kemisha Shaw Kelly, Program Development Officer from the Family Health Unit at the Ministry of Health and Wellness. It is my pleasure to lead you through the Scientific Session 1, Non-Communicable Diseases and Aging, the first session with our abstract research presenters. We are celebrating 15 years of research excellence, and now we enter into high gear with 4 research presentations in this session. We will have 2 presenters, and then we'll take our questions, and then we will have the other 2 presenters, followed by question and answer. Our first 2 presenters are Dr. Kathy-Ann Williams Harrison, a medical doctor practicing in public health since 2012. She completed her MBBS and Master of Public Health Management degrees at the University of the West Indies and is currently pursuing her Doctor of Public Health in Public Health degree at that institution. She works at the NCD Risk Factor Program Development Officer with specific duties in the NCD Risk Factor Prevention, Injury, Surveillance, and Injury Prevention. Next, we have Ms. Tonya Campbell. She is a PhD candidate in epidemiology at the University of the West Indies. She earned a Master of Public Health in Epidemiology at the University of Toronto and subsequently held various roles in both governmental and non-governmental settings, working as both an epidemiologist and research manager. With experience conducting and leading research on a variety of health issues, including foodborne disease, prescription drug utilization, and the opioid crisis. Ms. Campbell's research interests lie in the use of routine data sources to evaluate and improve health system and address health inequities. Please help me make welcome Dr. William Harrison.
Good morning, everyone. Thank you, Dr. Shaw Kelly. I'll present this morning on an initiative led by the Non-Communicable Diseases and Injury Prevention Unit in collaboration with a number of partners, a pilot of NCD screening clinic in Jamaica. The outline covers the concepts of the screening clinic pilot, some of the overview of the pilot, and some of the findings that we had with a brief discussion. We know the issue of NCDs in Jamaica. At the time of this pilot in 2022, NCDs would have occupied the top 5 positions in terms of the causes of death in Jamaica. And with increasing data, including data from our MOHW Vitals NCD edition in 2023, we see that NCDs and injuries occupy maybe the top 10 ranked positions for causes of death in Jamaica. The Jamaica Health and Lifestyle Survey indicates that many Jamaicans are unaware of their NCD diagnosis. We know the importance of early detection and diagnosis in the prognosis of our patients. We have national screening guidelines for NCDs in primary health care, which were established in 2020. And these were the foundation of the pilot that we initiated for this period, 2022 to 2023, for screening for NCDs and a few other conditions island-wide. So we had a sample of 134 persons. These individuals were recruited island-wide between the age 18 and 75 years. Persons were excluded if they already had a diagnosis of NCDs or they didn't have the cognitive ability to participate. Our participants received health education, age-appropriate risk-based screening, tests for 7 priority NCDs, diabetes, hypertension, and cardiovascular disease, 4 cancers, anemia, sickle cell disease, and STDs. There were also assessments of nutrition, physical activity, and oral health assessments were done as well. There was appropriate counseling and follow-up based on results. These were the participating facilities island-wide. We had one health center for each health parish. The flow of patients involved the recruiting by the team, community health aides, health education officers, etc. We used a number of tools, including brochures and promotions within the facilities and also in the communities, and we had the patients enrolled. We gave them their wellness booklets, the documents in the middle on the left, and this is a summary of our screening guidelines for NCDs. Individuals were screened for their risk for NCDs, and based on this information, they were given appointments for screening. They were screened and sent for investigations. These results were gathered, and they had follow-up appointments, and they were appropriately referred if there were positive results from screening. The team is listed here. It was multidisciplinary. Training sessions were held for all individuals prior to the start of this screening clinic pilot. So with our results, we had 88 persons, more females than males, as usual, you know how it will be. Median age, 41 years, median BMI, 27.4, which is our overweight category. We had some conditions that were noted to have greater percentages of high-risk profiles for NCDs, and these were hypertension and cardiovascular disease, diabetes, depression, prostate cancer, and breast cancer. And in terms of positive screening outcomes, we had depression, 23% of the sample, hypertension and cardiovascular disease, just about 17%. Physical activity, the males outran the females, 2.5 days versus 2 days. We noted, in terms of risk factors, inadequate consumption of fruits, vegetables, and legumes, but adequate or excessive consumption of sugar, salt, staples, and fats. We had interviews for participants, both the patients as well as the staff who would have worked with these patients through this pilot. The patients said their pros were the free services that were available and the focused attention from healthcare providers. The cons were that the inconvenience of going to different locations to conduct laboratory tests. So some tests were offered within the public system, some weren't readily available, and within the time frame for a good turnaround time for the pilot, we participated and collaborated with private laboratories as well for radiological investigations for breast cancer, colorectal cancer, and other screening tests. And we also collaborated with private labs in some cases. The patients recommended that the time spent at the clinic should fit within their work schedules, or there could be a consideration for clinics outside of regular working hours. The staff liked the ability of patients who needed the intervention to receive it, and that was offered through this pilot. And they also appreciated the training process. With the training, though, they would like to have received more training, and they said that some individuals did not receive all of the training prior to the pilot, but we did as best as we could. The staff recommended separate clinics for patients so that they could go through the screening process. And they also recommended that a pre-screening questionnaire be done for all patients entering health facilities, so they found this useful. Our conclusions were that NCD screening clinics can identify persons at high risk for NCDs, and this was proven through our clinic pilot. And in terms of the resources that we'll need for our pilots, the pilot showed us that clinics require effective health promotion, increased use of technology, and the availability of flexible time schedules for our patients. So with our ongoing primary health care and secondary care reform, we know that screening services are a priority, and we were happy to participate in this pilot, and we will note the results as we advance the healthcare of the whole human race. So we thank you for the opportunity to share, and thank you so much.
Good morning, everyone. Good morning, everyone. Today I'll be talking to you about some trends and patterns in premature mortality in Jamaica between 2010 and 2019. So health is a fundamental human right, and this was declared in the WHO's constitution and still remains true today. The untimely death of a person represents lost potential and has profound and tragic consequences for loved ones left behind. And this includes things like changes to family roles and structures and responsibilities, as well as finances, as well as impacts to the economy, including losses to productivity. Research has demonstrated that risk factors and exposures that are largely amenable to change, such as behavioral, physical activity patterns, and other lifestyle-related factors, are largely responsible for a large portion of premature deaths. And these mean that premature deaths are those that occur before the average life expectancy in a region. These lifestyle-related factors are actually driven themselves by factors lying upstream, such as wealth, social status, and inequalities in these factors. So premature mortality can largely be avoided through appropriate investments in health and social-related policies that target these upstream determinants of health. And therefore, the prevention of premature death is a key aim of societies worldwide, as well as a target of the 2030 Agenda for Sustainable Development. In Jamaica, we have a preliminary understanding of premature mortality, and this is thanks to the Ministry of Health's Vitals report, which was released in 2023 and shown on the right-hand side of the slide. So that report showed us that there's been some evidence of rising rates of early death due to leading non-communicable diseases in Jamaica, including diabetes and cardiovascular disease, with some variation by sex. However, more work is needed so that we can understand these trends more broadly, as well as trends and patterns in all-cause premature mortality, a regional variation in premature death, as well as patterns across demographic subgroups, for example, across age groups, as well as all underlying causes and social drivers. So the objective of this study was to describe trends and patterns in all-cause and cause-specific premature mortality in Jamaica between 2010 and 2019, overall, as well as by age and sex. And this is the first in a series of 3 studies in fulfillment of my PhD. So this was a population-based descriptive ecological study, and we obtained data on registered deaths from the Registrar General's Department. These were our numerators. For our denominators, we obtained data on population estimates, which were annual mid-year population estimates from the Statistical Institute of Jamaica. So we included in the study Jamaicans who died between January 1st of 2010 and December 31st of 2019, and we excluded people who resided abroad at the time of death. And so our primary outcome was premature mortality, measured as the years of potential life loss before age 75. And the diagram on the right-hand side of the slide can show you how we calculated that. So for each person who died prematurely, we took their age at death and subtracted that from the threshold age of 75, which was determined based on the life expectancy in Jamaica. And so for a person who died at age 65, this would be 10 years of potential life lost, whereas for an infant who died at age 1, this would be 74 years of potential life lost. And so we repeated this process for all premature deaths in the population and summed the number of years of life lost for all deaths and came up with a total value for the population. And so this is what we measured. Our first measure was the crude rate of years of potential life loss per 100,000 population using a reference age of 75. In addition to that, we also measured the average number of years of potential life that were lost for each premature death, and we measured the percentage of all deaths that were premature. And we reported these metrics for all causes combined, as well as 8 major causes. And this includes maternal and perinatal conditions, infectious and parasitic diseases, neoplasms, endocrine and metabolic disorders, circulatory diseases, chronic respiratory diseases, digestive diseases, and external causes. And that includes things like accidents and injuries. So our measures were calculated annually for the entire population overall, as well as by age and sex. And as I said, we expressed our rates per 100,000 population. We then used join point regression to identify statistically significant changes in trends and to estimate the average annual percentage change in rates of premature mortality over the study period. And our trends were characterized as increasing or decreasing if the estimated slope differed significantly from 0. So for our results, we found that there were almost 90,000 premature deaths among Jamaicans below 75 years of age, and this accounted for about 53% of all deaths. So the percentage of deaths that were premature was slightly higher among males at almost 57% compared to females at about 48%. The average age at premature death was 52 years, and we found that there was a significant increase in all-cause premature mortality for the entire population overall, as well as for both sexes. So the graph on the right-hand side of the slide can show you that. The black line shows you the overall rates, and the purple line shows you the rate among females, and the blue line shows you the rate among males. So we saw that in 2010, the rate of premature mortality was about 7,000 per 100,000 population, 7,000 years of potential life loss per 100,000 population, and this increased to almost 8,500 years of potential life loss per 100,000 population in 2019. This corresponded to an increase of about 1.4% per year, and this was slightly higher for females at 1.9% compared to males at 1.1%. When we looked at causes or rates of premature death by age, we saw that the highest rates were in the 50 to 69-year age groups. So this is in the green and blue lines at the top of the graph on the right-hand side of the slide, as well as very young ages, so 0 to 14 years, which is the pink line in the middle of the graph. And we also saw that there was significant increases in rates in these same groups. In contrast, we saw a slight reduction in premature mortality in the 30 to 39-year age group. When we looked at causes by sex, so females are in the graph on the left-hand side of the slide and males are on the right-hand side. We saw that across both sexes, neoplasms, which is the green line, circulatory diseases, which is the red line, and maternal and perinatal conditions, which is the pink line, were the leading contributors to premature death across both sexes. And we saw also an increase in endocrine disorders, particularly for women, in the blue line, and a decrease in external causes, particularly among men, in the yellow line. We also saw that infectious diseases played a stable and relatively substantial role to premature death across the study period. When we looked at leading causes by age, there's a legend on the right-hand side of the slide to help orient you. We saw that there were some differences across the age spectrum. So earlier in life, we see more of a contribution for maternal and perinatal conditions, infectious diseases, and external causes, whereas later in life, we see more of a role for chronic conditions, such as neoplasms, circulatory diseases, and endocrine disorders. And finally, when we looked at the average number of years of life lost per premature death, we saw that on average, there was, in 2019, there was an average of 22 years of life lost per premature death in Jamaica. And this differed slightly by sex, so females are in the purple on the graph, and males are in the blue. So except for digestive diseases and external causes, as well as maternal and perinatal conditions, which aren't in the figure, females actually lost slightly more years of life for each premature death compared to males. So this analysis is not without limitations, the biggest being that coroners' cases are currently missing from this, and so rates of premature mortality presented here are underestimated, particularly for external causes. And so this is something we're hoping to overcome soon with some additional data. In addition, these analyses relied on death certificate data to determine the cause of death, and so any limitations in data quality could introduce some errors in the cause-specific estimates. And finally, these analyses do not include trends by other important sociodemographic characteristics, such as urban versus rural region of residence or socioeconomic status. But again, this is something that we're hoping to overcome with some additional data. In conclusion, premature mortality is on the rise in Jamaica, and leading drivers include cancer, cardiovascular disease, and maternal and perinatal conditions, although endocrine disorders, external causes, and infectious diseases still play a considerable role. Important gains have been made in some areas, such as in the reduction of deaths due to external causes and in the 30 to 39-year age group. But these results call for the development of new and the strengthening of existing policies to address high-risk groups and common causes. And finally, the limitations that I pointed out call for additional collaborative research in Jamaica and in the Caribbean more broadly to help deepen our understanding of these trends, as well as social drivers and economic costs, as well as to develop shared solutions that are relevant to a Caribbean context. So I would like to thank my study team and the advisory committee, as well as the data providers, and thank you all for listening to my presentation.
Excellent, very clear and informative presentation. The floor is now open for comments and questions.
question is, what are the areas identified that could make the program sustainable, or any identified barriers to the program becoming a staple in provision of healthcare to our population?
And this
Dr.
question
Kathleen.
is okay.
Thank you for that. Thank you for that question. The screening clinic occurred during the normal working hours in most cases, and so we had the same staff that would have been carrying out other clinics participating in the screening clinics for that period, for the time of the pilot. So as pointed out by the staff and the patients, or implied from what the patients had said, devoted time for just screening for individuals would be ideal. In terms of barriers, the patients pointed out discomfort with going to different sites. Of a truth, all the screening tests for NCDs aren't readily available in the public sector at this point in time, and definitely at the time of the pilots, mammograms, colonoscopy weren't streamlined and readily available within the public sector. So we did participate with our partners in the private sector to have mammograms and colonoscopy offered for individuals, and some of our screening tests or blood tests and our fecal occult blood tests were also done with private labs, and this highlighted the importance of collaboration, the importance of the multidisciplinary team, the collaboration between private and public sector for the services for screening in Jamaica until we can optimize the services that we do have available. The staff also pointed out as a barrier the training. We did do training for staff, but there were some who pointed out that they didn't have enough training. So we can always improve on that and ensure that all the participants do have training. And lastly, for some of the additional assessments that were done, for example, for physical activity assessment, the physical activity specialist was not always available to participate in all of the clinics. So the additional services weren't always readily available for each clinic session. And that's something, when we have the appropriate number of staff, that we can look to optimize on. So thanks for that question.
Thank you. There's one more question for Ms. Campbell. The question follows: very good presentation, but where do we go from here? What are the recommendations?
Great question. Okay, I think first, more research, as I mentioned. So we have a basic understanding of these trends, but we need to really understand why we're seeing some of these trends. So as I mentioned, there's a need for research to really understand these patterns in specific geographic regions, so by parish, by community, so that we can really start to drill down into the community-specific factors that may be driving these premature deaths and help to enhance access to services like screening or immunization, et cetera, that can really target some of these reasons that people are dying prematurely. So first, I would say more research to understand the community-specific drivers, and then action, so collaborating with policymakers across different sectors to come up with solutions that target the findings of that research.
Okay, and one more question for you. In your opinion, what perinatal and maternal factors are contributing to the premature death in our females?
Great question. I haven't dug into the specific causes of death in that category, but that's something that I will do. So I don't have an answer right now, but I will by the time the paper is done. So to be continued.
Thank you.
Okay. No other question or comment? If not, we'll move to our final two presenters. And they are Dr. Neville Cunningham. This Cornwall College old boy hails from the parish of St. James. He is a young anesthetist from the University Hospital of the West Indies with a keen interest in geriatric anesthesia. This interest, and under the tutelage of his mentor, Dr. Patrick Toppin, he embarked on research focusing on frailty in the elderly surgical population at the University of the West Indies. His goal is to offer tailored care in the near future to one of the most vulnerable set of individuals in our society, the elderly. Then we have Dr. Debbie Thompson. She is a senior research fellow at the Caribbean Institute of Health Research at the University of the West Indies. Dr. Thompson holds a postgraduate diploma in dermatology from the University of London and a PhD in nutrition from UA. She has participated in a range of research projects investigating the associations between early childhood exposure to severe acute malnutrition and adult body composition, glucose metabolism, cardiovascular structure and function, non-alcoholic fatty liver disease, and metabolism. Please help me make welcome our presenters.
Thank you. Good morning, everybody. As previously said, my name is Dr. Neville Cunningham from the University Hospital. So in our study, what we've been doing is we've taken a look at the prevalence of frailty in the elderly surgical population at the UWI. In terms of the order of the presentation, it's actually very good that we spoke about babies just now, and now we're talking about the older folk. What we'll go through is a quick definition of frailty, the risk factors, and then get into the meat of the matter, which is the screening tools that can be used and what we utilize and what our study had actually looked at. So when you think of frailty, we always focus on the other extreme of age, which is the pediatric population, and we speak a lot about failure to thrive, etc. But frailty, what is it? So it is a state of increased susceptibility to any stressor that has the potential to lead to suboptimal outcomes. What it involves is the regression in function and reserve across various physiological systems. And these systems include the central nervous system, so you can have cognitive decline, a decline in the immunological system, so you're more susceptible to infections, etc. When you think of frailty, commonly we think frailty equates to older age, when in reality, even though there's a correlation, it is not synonymous. Because if I have a 72-year-old versus a 61-year-old here, there is a chance where the 61-year-old can be more fit than the 72-year-old. So frailty goes beyond chronological age, and that emphasizes that there's not just a biological component, but also a functional decline in these patients. Now, the risk factors are multiple. They are physiological risk factors, medical illness, socio-demographic, and psychomotor. As clinicians, with our research, we wanted to do something that would be tangible in the clinical setting. And in our population, we've been looking at data that looks at patients in North America, the UK, but nothing in terms of local data. And the aim here is really to get a look at our population. So medical illness, we're a black population predominantly. Most of our patients have hypertension. Studies done in the United States even show that frailty shows a greater correlation in patients who have cardiovascular diseases, diseases such as strokes, cancer, and such. Socio-demographic factors, our study will even show it, and other studies have shown that lower socioeconomic status, which is evidenced by lower grade of education or income potential, are hallmarks or puts patients at greater risk of frailty. And then disability. This is a little bit of a tricky thing, because now the question is, am I frail because I am disabled, or does my frailty contribute to my disability? So even studies need to be expanded. So it is a very wide field that is still untapped. When screening, there are two umbrella concepts when you talk about frailty. You have deficit accumulation and phenotypic frailty, or physical frailty. Deficit accumulation looks at the presence of your comorbidities, the amount of medications you're on, your social factors, while phenotypic looks at your symptoms, how weak you are, how slow do you walk, a decrease in gait, strength, and such. So the tools that are available are the frailty phenotype assessment, the frailty index. Now these tools, if you're a researcher and purely a researcher, these tools are good. But as I said earlier, we're clinicians, so we needed to do something that is reproducible in the clinical setting and something that is rapid. So they have these rapid tools available. which are listed here. What we decided to go with was the Edmonton Frail Scale, which was developed by the University of Alberta in Canada. They saw that patients were showing outcomes of delirium post-op, and even though it was in the older population, age was not a direct correlating factor. So they said, what is going on? So in 1999, they came up with the tool, got it validated in 2006, and here we are. We use it in our setting. So it assesses multiple domains. Cognition is the first thing on the test. What we did was we had individuals just look at the face. That circle is the face of a clock. And you'd put the numbers where they're supposed to be, indicate a time of 10 after 11, and then we assign a grade, whether or not you passed, whether or not you mildly failed, whether or not you severely failed. And what we found is that a lot of people actually had trouble with this test, but it was more so the frail people who really suffered. I myself, at first glance, had some difficulty with it, actually. The other aspects of the test looked at, as we said, cognition, general health status, functional independence. I could go through the list if I had more time. But what it does is that it's a hybrid tool that looks at both deficit accumulation and the phenotypic. So we found it, and it's rapid. This can be done in 5 minutes. Only outside of the clock, the functional performance, which is a stand and go test, is the only true physical thing that the patient would have to do. So what did our study look at? We looked at the evaluation of prevalence in the over 59-year-old population. How we came up with the age, World Health Organization says older population, greater than 60 or more. So we said, okay, we'll use 60 or more. Well, it was a prospective observational study. Informed consent was received for all those who met the inclusion criteria. Patients who had dementia or significant visual impairment, they were excluded from our study. And once we got informed consent, we went about and we did our assessment tool. So we were able to get 209 patients to be included in our study. The mean age was 70, and 53% of those patients were female. Over 60%, which is a reflection of our society, fell within the overweight or the obese group. And for our primary outcome, which was the prevalence, we found that 40% of patients were classified as frail and 8% as severe frail. So just to look back at the Edmonton Frail Scale, when we assign a tool, it gives patients a score, whether or not you're fit, whether or not you're vulnerable, and then varying degrees of frailty from mild, moderate to severe. What we found was that frailty was associated with an increased age. This is actually a typo. Female gender, lower hemoglobin counts, and a lower levels of education. So it even matches what we were speaking about in terms of the risk factors and the pathophysiology involved in frailty. So our study looking at our population actually showed that. Patients admitted for neurosurgical and orthopedic procedures had a higher prevalence of frailty. But these patients too were the ones who had greater disability. So once again, we need greater numbers, more studies to see whether or not am I disabled because I'm frail or vice versa. So this is just looking at the population characteristics which we just discussed in actual prose form. Most of our patient population had hypertension. In terms of what was statistically significant, age was, even though we did see the relation in terms of BMI and gender, there was no, our analysis never showed us any statistical significance. But we want to power study greater by having greater numbers of patients, which is the plan. Socioeconomic status was also one of those things that was significant in our findings. So as much as I preached on the Edmonton Frail Scale as this ideal tool, there are limitations. Blind patients and those who are dementia, these patients meet the hallmarks of who you think might be frail. So it's likely that we would have missed patients who would have contributed to our numbers being greater. And even looking at the data, when we were trying to come up with, not us, when researchers were trying to come up with a Caribbean frailty tool, the incidence of frailty in the local population was as high as 60%. So our studies really showed ranges from anywhere from 7 to the 30s, but that was really in the first world, the United States, UK, and some areas of Latin America, but not specific to our area. So the conclusion is the prevalence of frailty in the study was much higher than in most of the published data, but once again, we're trying to establish something for our local scenario. And then medical and socioeconomic factors play a significant role. Now, a question that will be asked at the end of this presentation is, what do we do with this study? Now, I said this, and I think this is the third or fourth time. We are clinicians, right? And as clinicians, we want to say, how can I change? And especially as an anesthetist, my goal before putting my patient off to sleep is, how can I optimize your condition? And there's this thing called prehabilitation, where you try to get your patient in the most perfect or the most optimized state both from a mental, a physical, and a nutrition standpoint. And what we want to do is we want to identify our patients who are frail. And what our study actually showed was that the time in hospital for these patients are greater. We want to limit, we want to have the best use of our resources, and having patients in hospital longer is just not the best use. So if we can identify them from the before you get on the bed, if I can find you, optimize you, and the government is doing such a good job in terms of the multidisciplinary approach to the care in hospitals. We have the doctors, we have the pharmacists, we have the physiotherapists. All of these guys can play a role in caring for these patients. I have 1 minute left, but I actually practiced for a 10-minute presentation. So I'm actually finished. If there are any questions, I welcome them. Oh, the questions come next. My bad. All right. Thank you.
Thank you. Good morning, everybody. And thanks for the opportunity to share our findings on our study, which looked at the associations between severe malnutrition in childhood, rehabilitation weight gain, and adult adiposity. So by way of a background, severe malnutrition is defined as the presence of nutritional edema or severe wasting. And severe wasting can be measured or related in two ways. It can be a weight for height, Z-score, that is less than 3 standard deviations of the WHO growth reference median. Or it can be a mid-upper arm circumference that's less than 115 millimeters. Now, in severe malnutrition, the aim of nutritional rehabilitation is usually to prevent mortality and restore normal anthropometry, normal body size, as quickly as possible. Now, there are several studies in the literature that suggest that children who experience prenatal undernutrition, therefore they're either low birth weight or small for gestational age, that these children, if they gain significant weight later in life, they could be at risk for cardiometabolic NCDs, non-communicable diseases, such as diabetes and hypertension. Now, it is unclear whether children who experienced postnatal malnutrition, so the type of malnutrition that I'm interested in, are at similar risk of cardiometabolic NCDs after nutritional rehabilitation as part of the care and management of severe malnutrition. So there are several observational studies in the literature that suggest that this association might indeed exist, but the association is not well understood, and the drivers of this association, the drivers are not known and have not been identified. So this study aimed to explore the association between the severity of malnutrition, the rate of weight gain during nutritional rehabilitation, and adult cardiometabolic risk in a cohort of adults who are admitted to the TMRU ward as children with severe malnutrition between the years 1963 to 1995. Not 93, that's a typo there. And the study aimed to explore whether and how the severity of undernutrition and the rate of rehabilitation weight gain impact adult adiposity. And we were using adult adiposity in this instance as a proxy for cardiometabolic risk. We also wanted to examine other factors that could influence these associations. So this is our conceptual framework for this study. And the solid arrows represent associations that are fairly well established in the scientific literature. Whereas the dotted arrows represent our hypotheses and the plan for what we wanted to investigate in this study. So we wanted to look at the severity of malnutrition. We wanted to look at how that played into rehabilitation weight gain and how these two played into adult adiposity. In terms of our variables of interest, so Our main independent variable was minimum weight for age Z-score, which I'll refer to after this as MINWAS. And we were using that as a proxy for the severity of undernutrition, just how underweight this child is. Some other variables of interest were rehabilitation weight gain, which we measured in 3 ways. We used change in weight for age Z-scores per day, we used grams per kilogram per day, and we used grams per day. We were also interested in the role of sex as well as the presence of nutritional edema. And then as our dependent outcome, we wanted to look at, as I said before, adult adiposity, which again we measured in 3 ways. We use waist circumference because that's fairly easy to measure. But we also use fat mass and android fat mass, and those variables were derived from DEXA measurements. In terms of our methods, so this is a statistical, this is a secondary data analysis of data collected from 2 time frames. One was at the point when the children were admitted to hospital with severe malnutrition, and then roughly 10 or more years ago when we brought back these same children as adults during the JAMACA study and measured them again. Now, we use unadjusted analyses to identify correlations between the independent and dependent variables, and we use an informal forward variable selection approach to identify predictors of adult adiposity. We use a Barron and Kenny approach to assess mediators, and we use linear regression models to identify confounders. Measures of adult adiposity were regressed against quintiles of rehabilitation weight gain in 6 disaggregated models that were adjusted for adult age and weight for age Z-score. So this is what we found. As children, we see that on admission, the average age was about 360 days. In terms of differences between them, we saw that boys were more wasted, they were more underweight, and they were more stunted compared to girls at the time of admission. We also note that at the time of discharge from hospital, boys remained more wasted than girls. And even though it's not indicated on the table here, they were also more stunted and more wasted. So they came in that way and they left that way. Interestingly, boys and girls gained weight at the same rate throughout their admission, as indicated by the 3 measures of rehabilitation weight gain. Now, when we look at what happened with them as, did I miss a slide here? I'm sorry. I think there's a slide missing, but just to say that when we saw them as adults, men were taller, they had greater lean mass, whereas women had a greater BMI, greater waist circumference, greater fat mass, and greater android fat mass. So the women showed more adiposity than men as adults. Now, when we look at how the measures of adult adiposity stacked up or compared with our rates of growth, we saw that delta was per day, so change in weight for age Z-scores per day, and grams per kilogram per day were positively associated with waist circumference, fat mass, and android fat mass in men, not in women. When we looked at the sexes together in that first part of the leftmost side of the table, yes, all of these associations are positive, but when we separate them by sex, we see that these relationships only hold fast with men. When we looked at the factors that predict adult adiposity, we found that in respect to waist circumference, adult age was the main driver of waist circumference, whereas when it came to fat mass, female sex was the main driver, along with, and similarly for android fat mass, female sex was the main driver. In terms of our results, further results, When we did our correlation, so we saw that minimum weight for age Z-score had a direct and positive association with waist circumference as adults, fat mass, and android fat mass. When we examined our other variables of interest, looking at edema, sex, and rehabilitation weight gain, we saw that rehabilitation weight gain mediated the relationship between minimum WAS and adult adiposity, whereas female sex confounded the relationship. Edema played no role. In this very complex looking plot, what we did was a sex disaggregated analysis, and we looked to see how quintiles of weight gain stacked up against measures of adult adiposity. And what this is basically showing us is that, again, was there a relationship between the highest rates of weight gain and adult adiposity. So this relationship did not hold true in women. And this was a threshold effect. It was weight gain exceeding 13 grams per kilogram per day. It was in those instances where we found the association with adult adiposity, but only in men. So I know I'm out of time. My key message is children who were least underweight at the time of admission for severe malnutrition, they experience faster greater adiposity as adults. Now, our results add to the growing evidence of sex differences in severe malnutrition, as boys were not only more prone to becoming more severely malnourished in the beginning, but they were also more susceptible to the long-term effects of faster rehabilitation weight gain. We submit that these findings should be explored in future interventional trials using different feeding regimes. I acknowledge the funding partner and my collaborators, and thank you for your attention and patience.
Thank you. The floor is now open for comments and questions.
Okay. All right. The question asked is for Dr. Cunningham. You mentioned the limitations to the tools used. Why did you not use two measuring tools to minimize the fallout in your study?
Hello? Okay, good. So, as I said, we were a bit confined by the time restrictions. I could have actually went very much deeper into the tools that we utilize. The gold standard tool, which is the free tool, is actually very time consuming. So it would have been an ideal tool to be utilized if in the research setting, but trying to find a tool in the clinical setting, it's not very feasible to use those other tools. In our study, the Edmonton Frail Scale it's been validated, and they've actually done other studies that have shown great correlation between the findings from that and the findings from the more exhaustive, primarily research tools. The drawback is, the drawback to using the gold standard tool is it requires specialized equipment, and even though I do have some of that equipment available to me, we wanted to do something that was reproducible. So not just at the UA, but also we wanted to include other centers, because anesthesia surgery is done at so many hospitals. So I wanted to be able to do something at UA, something at KPH, and also I wanted to do something at Noel Holmes all the way down in the west, Savannah Lamar Hospital, for example. So that's the reason why we had no problems using just the Edmonton Frail Scale, considering the correlation and the validity of its use.
Can go ahead.
Thompson. Dr. Thompson. prematurity.
No. No, it was not. Because in many instances, we did not have had children coming for admission, they married. They or may not have had reliable data. 1960. Bear in mind the time frame and what was collected.
Dr. Thompson, what specific lifestyle changes or interventions can women implement to mitigate the effects of hormonal or metabolic changes on weight gain as they age, especially in comparison to men?
Well, I think the message is the same for both men and women. And it's typically what the ministry, various ministries recommend. So based on the findings of this study, we see that women have greater adiposity. And of course, diet is going to determine, but physical activity is also. I don't think this study suggests that there's anything, the results of this study, I should suggest that there's anything that women should, different from men, say. I think the message is the same. I think from the perspective of this study, we are more conscious. What is happening with boys are more susceptible to malnutrition, and they're more susceptible to our efforts make their normalize their. So that is the rising part. And whether or not we need to think about the rates of weight gain to engender. Bear in mind that recommendation from former WHO recommendation that weight gain of 10 grams per kilogram per day is considered good weight gain. And we are finding in our population, men who gain, boys gained weight of 12.9, call it 30 grams per kilogram, have greater adiposity as adults. So it seems to me that what we need to think about is somehow and considering what is an upper acceptable during nutrition and balancing that need to, prevent death, because a lot of times that's the goal. We don't want these children to die. We want them. Then we have to balance that. If we make them weight too, this can have long-term effects. So it's balancing short-term and the long-term.
You can go ahead.
Good morning, Dr. Cunningham, or afternoon. One of your findings related to the sample size at the lower level education, but I'm wondering if that could just be related to the population that access care at the institution.
So that is a fair question that can really only be answered with assumptions. Because I would make the assumption that because the universities a lot of these patients have to actually pay before they get service versus the fully public hospital where service is rendered for free. So I'd make the assumption that if you're able to foot this sometimes relatively high bill, then looking at socioeconomic status, which is a marker that is income, then I would make the assumption that we would see a little bit of a higher status of patients. So we'd have to do separate analysis of that on its own, but it is a fair question to ask. What we did notice, though, was that irrespective of what population seeks care at UWI, the findings were in keeping in terms of frailty being associated with socioeconomic status as the international studies that were done. So, fair question. I wish I had a longer study period with a greater patient population to fully answer. Thank you.
You can go ahead, Dr. Dawkins, right?
Thank you. And good afternoon, everyone, and great presentations again. I must commend the team as well. I wanted to ask Dr. Cunningham, it's really just for clarification in terms of the study procedures. I may have missed it, but whilst you were presenting the information on the slide, in terms of whether the index of frailty was associated with less favorable outcomes, and I think you mentioned it in the comment you were making at the end, that it did appear to be an association with longer stay in hospital post-op. So just to confirm that that was a finding within the study. And the second part, in clarification, was it that these persons were identified as being more frail and so they were kept longer, or was it that it was observed as part of the study?
So for the second part of the question first, no. So when we actually did these studies, a lot of times it's when we go back and now we're accumulating our data and then we're looking back at the patient files to see how long they would have been in hospital. That is when we would realize, oh wow, those who we actually calculated greater frailty are the ones who stayed in hospital longer. There was an observation. In terms of who was frail versus not, the clinicians, both anesthesia, both surgery, no one was privy to that information. So it was an actual observation. In terms of the outcome, so the primary objective of the study was to look at prevalence. Initially, we did want to look at other perioperative outcomes, but I guess the medicine that we practice is just so good that there was just so little in terms of poor outcomes that there was nothing to analyze. I think we had maybe, of the 206, there were like 3 deaths. So the only thing that was worth analyzing and actually was of any significance was the length of stay in hospital. And then it was actually good that we found that because that can also help in terms of guiding public policy because of how expensive healthcare is. So the hope is that once we actually publish this, we can present it to the ministry so that we can put more, prevention is better than cure. So we can put more attention into doing rehabilitation instead of trying to focus on rehab because there's a lot of benefit in doing rehabilitation for these patients, which in Dr. Toppin and some of the other guys at the university, they're actually doing other studies looking at this. So if anything, this is like a gateway study to really fully understand what goes into the care of the elderly population in our setting. So thank you for that question so that I got the opportunity to clear that up.
Thank you.
And we have 2 more questions. You
Yes,
can
we
go
have
ahead.
2 questions online, one for Dr. Thompson and another for Ms. Campbell. Looking at your statistics over of undernutrition in the population or seen at your facility?
Indeed, we are. So, in fact, the TMRU board, which is from the 1950s, excited as the administration sustainable. And I think what that means is that a job was well done in the sense that the outlying clinics were better equipped than any hot malnutrition early before it became severe. And so children could be then referred without the need. Yes, but even that admission rate really going down. How that speaks to what is exactly going on and in the community, I would have to guess, but I suspect.
Okay, thank you. And Ms. Campbell, great presentation. Do you think that the marginalization of males are why they are dying so, or is it because of crime and violence?
So I think as a preface to this question, I think I need to do a little bit more work to dig into causes of death as part of this research. But I would say what I noticed for males is that there's a high role for cardiovascular diseases as well as external causes. So from my look at the data so far, that's what we see are the major drivers for mortality rates higher than. Being said, we also see factors for women being neoplasm. So I think we need to look at both sexes as well and really identify the causes as well as the factors that are driving deaths across sexes or both within both sexes, and really address those factors in policy.
Okay, thanks. That is all.
Okay. So thank you for joining us. We will now break for commercials.
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in at the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for you, your sake, and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I think they're ready for us now.
Good afternoon, everyone. Welcome to the scientific session 2, where we'll focus on the SALT study. I'm your chair for this session, Dr. Tamu Davidson. We will have our, scientific session 1, and our feature presentation for this afternoon will be focused on the Jamaican salt consumption study. And our guest is no stranger to us. Our guest today is Professor Trevor Ferguson. Now, Trevor Ferguson is the Professor of Epidemiology and Internal Medicine and Director of the Epidemiology Research Unit at the Caribbean Institute for Health Research at the University of the West Indies. He is also the Honorary Consultant in General Internal Medicine at the University Hospital of the West Indies. He is also a Fellow of the American College of Physicians and the Royal College of Physicians of Edinburgh, and a Bernard own scholar in cardiovascular health at the Harvard T.H. Chan School of Public Health. He currently serves as the chair of the Jamaica's National Committee on NCDs. And so, without any further ado, I'm going to invite Professor Trevor Ferguson up to give this featured lecture presentation. Please give him a round welcome, and we like to say Louis Bennett applause. So if you're online, please make sure we can hear you loud and clear.
All right, so thank you very much, Dr. Davidson. Let me thank the Ministry of Health and Wellness for providing this opportunity for us to share some of our research findings and to share with the wider audience what's been happening with salt consumption in Jamaica. So the title of this presentation, the Jamaica Salt Consumption Study, we're looking at sodium intake, sodium content in restaurant foods, knowledge, attitudes, and practices, as well as spot urine sodium validation. So this study is a collaborative research project between the Ministry of Health and Wellness, the Caribbean Institute for Health Research, and is funded by the National Health Fund. The overall aim is to obtain baseline data on salt consumption in Jamaica, salt content in restaurant foods, and to evaluate knowledge, attitudes, and practices of Jamaicans regarding salt consumption. So why is this important? Why are we taking all the time and effort to learn about salt? So I'm sure some of us have had some salt for the day because it's fairly a ubiquitous product. So salt, or sodium chloride, is a major component of the food supply in most countries. It is commonly used to flavor food as a, okay, that moved too fast, as a binder and stabilizer, and also as a food preservative. Now my slides are doing their own thing. Is somebody else moving my slides? All right, let's see, are we at the right place now? All right, so slides behave. Okay, let's get right back to it. So in terms of what is the physiological role of sodium in the body, now humans require a small amount of sodium for daily body functions, and this includes important functions such as nerve conduction, the skeletal muscle contraction, also in the regulation of blood pressure and in the regulation of fluid balance. The main source of sodium in the diet is from table salt, or sodium chloride, but other sources include monosodium glutamate, sodium bicarbonate, commonly known, of course, as baking soda. Now, most persons consume between 9 to 12 grams of salt per day, and this translates to about 3,500 to 4,700 milligrams of sodium, and is 1.5 times to 2 times the recommended maximum level of sodium intake. Where do we get salt from? So most of our sodium comes actually from processed foods and foods prepared outside the home. However, in developing countries in particular, salt is often added during cooking, and some persons also add salt at the table while eating. So it's important to recognize these potential sources of salt and to take the necessary corrective measures. Now, with regards to global sodium consumption, this is estimated to be high worldwide. In 2010, mean sodium consumption was estimated at 3.95 grams per day. Intake was higher in men and was highest in the East Asia and lowest in sub-Saharan Africa and Latin American countries. Updated estimates from the World Health Organization in 2023 suggested that sodium consumption may be increasing with an estimated sodium consumption of 4.3 milligrams per day. Now, high sodium consumption is associated with multiple adverse health outcomes. And this slide illustrates the various organ systems as well as the clinical manifestations of high salt consumption. So we see that high salt consumption is associated with high blood pressure, with ischemic heart disease, hypertensive diseases, heart failure, also associated with stroke and dementia, with chronic kidney disease and kidney stones, with stomach cancer, osteoporosis, and obesity. And it is estimated that these together are responsible for approximately 3 million deaths globally. Now, the WHO, in their response to the challenge or the problem related to excessive salt consumption, have published guidelines or recommendations in the SHAKE technical package. And the main pointers, of course, is that they recommend that sodium consumption should be less than 200 milligrams per day. Countries should target a 30% relative reduction in mean population sodium intake by 2025, and the SHAKE package should be used as a guideline for member states to assist in the implementation of sodium reduction strategies. Now, in addition to sodium, potassium is also important, and studies have established that low potassium intake is associated with several non-communicable diseases, including hypertension, cardiovascular disease, kidney stones, and as well as low bone mineral density. Now, an increase in potassium intake can reduce blood pressure, can also reduce cardiovascular disease, and mitigate the negative consequences of a high sodium diet. The WHO therefore recommends that persons should increase potassium intake from food in an effort to reduce some of these adverse outcomes. And the recommended intake for potassium should be greater than 3,500 milligrams per day for adults. So on this background, the Jamaica Salt Consumption Study had 4 main objectives. These were to estimate dietary sodium consumption among Jamaicans using spot urine sodium analyses, to evaluate sodium content in commonly consumed foods sold in restaurants, to conduct a baseline survey on current knowledge, attitudes, and practices regarding salt consumption in Jamaica, and to evaluate the accuracy of spot urine sodium as a measure of dietary sodium intake in the Jamaican setting by comparing this with estimates from 24-hour urine collection. So what have we done so far? We have published the study protocol that's available online, and so persons can check with this link. So it's published in F1000 Research, and you can learn all about the things that we're doing and the methods we're using and have access to our questionnaires, etc. So these tools are available for persons who are interested in this area of research. Now, the study was divided into 4 components based on each of the 4 objectives that we had mentioned. So the first component focused on spot urine sodium analyses, and this was done urine samples that were collected as part of the Jamaica Health and Lifestyle Survey in 2016 to 2017. From this study, we estimated mean 24-hour dietary sodium consumption, mean 24-hour dietary potassium consumption, and the proportion of participants who had high dietary sodium or low potassium consumption. And we also evaluate associations with factors such as sex, sociodemographic factors, and other participant characteristics. Our first output from this study, we presented our findings at the 2022 CARFA conference, and also presented at the 2022 Ministry of Health National Health Research Conference, and finally published the findings in the journal Medicine. So what we found here was that mean population sodium consumption was 3.6 grams per day, and this was significantly higher than the recommended 2 grams per day from the World Health Organization. Mean potassium consumption was 2.1 grams per day, again, significantly lower than that recommended by the World Health Organization. When we looked at the proportion of persons with high sodium consumption, this was found to be 67%, and 89% of Jamaicans had low potassium consumption. So from this, clearly there is quite a bit of work to do as we seek to correct these anomalies. Now, for the second component, we focused on salt content in foods sold in restaurants. And for this, we created a database of restaurants in Jamaica. We obtained data from the Companies Office of Jamaica, as well as searched through the Yellow Media pages for listed restaurants. So we were able to compile this database, and we focused for these analyses on chain restaurants, which were defined as having greater than or equal to 3 branches locally. For the chain restaurants, we contacted restaurant owners and managers to obtain information on meal items sold in each establishment, as well as available nutrient profiles, recipes, and ingredient listings. We were able to administer questionnaires to 7 of 29 chain restaurants, so the restaurant owners and managers weren't too keen on answering our questions, but we got some data. And we also compiled the data on menu items from these restaurants, and we will use the menu items to assess nutrient content using data from the USDA Food Central database. And from this, we expect to estimate mean sodium content per menu item sold, as well as the proportion of foods with high salt content. And for this USDA analyses, we have one of our MSc nutrition students working on these analyses, so we should be able to have something to share shortly. With regards to the interviews done with restaurant owners, we have prepared a poster which is part of this conference. So we're not going to go through this poster now, but I invite you all to go to the poster site and take a look at the findings that we had from the interview with our restaurant owners and managers. All right. So Google is listening. Okay, so in terms of the third component, here we aim to recruit a nationally representative sample of 1,200 participants, and we administered questionnaires to evaluate knowledge, attitudes, and practices regarding to salt consumption. We also measured weight, height, blood pressure, and collected spot urine samples for estimating sodium excretion. We were able to enroll 1,002 participants, of which approximately 490 provided spot urine samples. So with regards to the data on the sodium consumption, we will have an update in this afternoon's session. So again, I invite you to be here at 2 p.m. when we share the findings from the analysis of our spot urine samples. And I'll give a little sneak preview that we may have a little bit of goodish news. All right. With regards to the validation study, here we targeted a sample of 1,120 persons from whom we would collect 24-hour urine samples. And what we would do is also collect spot urine samples from the same participants and then compare the estimated 24-hour urine from the spot urine to that from the 24-hour urine collection. We were able to collect 109 24-hour urine samples and spot urine sample pairs, but of course, reflecting the challenges with 24-hour urine collection, only 64 met our inclusion criteria for validation study analyses. And those criteria were that we needed collection time between 22 to 27 hours, a minimum of 400 mils of urine and at least, not more than 4 days between the spot urine sample and the 24-hour urine collection. So again, we will be sharing some findings from the validation study in the session after lunch, and we will ask you to join Dr. Bennett for that presentation. So for the rest of this time, I will share a few of the findings on the knowledge regarding salt consumption from our survey. So this slide looks at Jamaicans' knowledge regarding common sources of salt in the diet. And we see that the participants were able to recognize some of the common sources of salt, such as salt added during cooking, the use of seasonings and sauces, also salted meats and fish as possible sources of salt. Persons, only a small proportion of persons, 37% recognize adding salt at the table as one way or one of the challenges regarding high salt consumption, and only 68% recognized bread and baked products as common sources of salt within the diet. Now, with regards to knowledge regarding the health effects of salt, again, we saw some differences. So persons were able to recognize that high salt diet would be a serious health issue. 97% of persons agreed with that. 94% recognized that reducing salt can result in significant improvements in health, and 97% also recognized the association between salt and high blood pressure. The proportions for other conditions associated with high sodium diet was much less well recognized, ranging from between 49% for association with stomach cancer to 75% recognizing an association with stroke. So while there is some knowledge, there is quite a bit that persons still need to learn. With regards to the salt content in commonly used foods, again, we see that there's quite a bit of variation in persons being able to recognize whether these foods were high or low salt. So they recognize with, in terms of some of the more common high salt foods, snacks and chips, etc., at 80-odd%. Only 16% recognize water crackers as a possible source of high salt. And I'm trying to find the section for breads, buns. Only 43% recognize breads and so forth as high salt food items. So again, there is quite a bit of variation, and there's quite a bit that we would need to educate the population so that they have a better index as to the salt content of commonly used foods. So we put all of this together in terms of knowledge scores, and this slide summarizes the knowledge scores. So we had, 3 knowledge scores reported here. Knowledge score 1 looked at general knowledge about salt content, about salt and health, and this included 20 items. So overall mean score for knowledge score 1 was 13.9. Knowledge score 2 looked at salt content of the different food items, and these were 19 items, a mean score of 12, and the combined 39 items, a mean score of 26. When we translated that to a percent, we see that these were mostly in the 60s, so 69% mean for knowledge score 1, 65% for knowledge score 2, and 67% combined. So again, this suggests that there's some deficiency in our knowledge of the salt content of foods and general knowledge about salt. So while it's not a failing grade, there is a lot that we need to learn. So if we need to get our persons closer to the 90% bracket in knowledge concerning salt. Now, in terms of the amount of salt that is recommended, interestingly, most persons thought that it would have been half a teaspoon, so less than the actual recommended amount, which is about 1 teaspoon. So while many people didn't get it correct, they were erring on the side of caution. So that wasn't too bad. This part is a little bit interesting, though, because when we asked persons what they thought about how much salt Jamaicans consume, so most persons thought that we had too much salt. So this overall 49% too much salt and 37% far too much salt. Only 8% thought it was just right, and a few had too little, etc. When we asked persons, though, about their salt consumption, we found that it was a little bit different. So most persons believe that they consume just the right amount of salt. That's 43%. And 36% thought that they consumed very little. So only 18% thought they were consuming too much, and 2% thought that they were consuming far too much. So we see that as it stands now, most persons would seem to think that everybody else is having a high salt diet, but they are just about right. So we will need to do a bit more. Of course, this corresponds with what persons, in terms of the knowledge scores, because some of the things that they would assume are okay are actually high in salt content. So just to summarize some of the implications from this study, which we will continue to share the findings, and we hope to have the full dissemination showing all the details of our findings in early January. Well, not early January, maybe late January. So gear up to come out and hear all the details of the findings. So this is the first national study with comprehensive data on salt consumption and also collecting data on knowledge, attitudes, and practices with regards to salt consumption. This enables the Ministry of Health to fulfill some of the requirements or the recommendations from the WHO Shake package. And as we have shared, so far we have documented high levels of sodium intake and low levels of potassium intake. And of course, these data will inform interventions to promote individual as well as population level reduction strategies. And the Ministry of Health is currently working on a national salt reduction program. So we will hope to hear about this in the more details of this in the near future. In terms of next steps, of course, we continue to work with the Ministry of Health in developing strategies for sodium reduction. We're currently working on a proposal to test the use of potassium-enriched low-sodium salt substitutes as a sodium reduction strategy. And what these salt substitutes involve is a mixture of 75% sodium chloride with 25% potassium chloride. And you use this instead of your regular salt in meal preparations, etc. And this will reduce salt content as well as increase potassium content. So we think that this is a useful strategy. We hope to get funding to have this study done. So we will keep you posted. We believe that there is need to further explore the nutrition composition of foods, particularly foods served in restaurants. As we pointed out, the restaurant owners weren't very keen to talk to us, so we really don't know what's going on in the restaurants. So we hope to be able to sample foods and to do the nutrition composition testing. And of course, we will need to continue to work with the Ministry of Health as well as non-governmental organizations to promote reformulation of foods to contain less salt and advocate for nutrition information to be made available for restaurant foods. So this is to acknowledge our team from the Caribbean Institute for Health Research, the Ministry of Health and Wellness. We also had some volunteer physicians working with the group, and of course our field team, without whom we would not be able to collect these data. So thank you very much, and we look forward to sharing more with you and to improve the health of our Jamaican people.
Thank you, Professor Ferguson. Now it's time for our Q&A session. Any questions online or on the floor? Yes, please go ahead.
Thank you so much for your presentation. A quick question. Did something Jamaica also food that are not fermented. There are ways that we test those food or the of those biological has high sodium content.
Okay, so we did have as one component of the study to look at the sodium content in packaged foods. There is another study that did collect data on that, and some of that has been reported. I don't recall the fine details. So the packaged foods would be would be the imported foods, and it's an important source of foods. And the packaged foods it would be relevant for both those that are imported as well as those that are produced locally. So that's an area that we need to also prepare the necessary reports on and ensure that the public is aware. The nutrition labeling promotions, which the Ministry of Health is currently doing, is one way to address that, because we want to ensure that persons are able to see what is the sodium and the other nutrient contents of the foods that are packaged and sold. And of course, there's a current challenge now as we try to get front of package labeling as one way to ensure that not only is the nutrition label that's on the back of the package, but also front of package labeling so that persons know exactly what they're eating. In terms of regulation, that is, I guess, a little bit more of a government responsibility. We work together in providing the evidence, and Dr. Davidson may comment. There are efforts to sort of regulate, or at least to have appropriate. The nutrition labeling is one way to look at that. But there are challenges as to how we can limit importation, but at least the appropriate labeling is important so that persons know what they're eating.
Thank you.
Okay, thank you. Yes, please go ahead.
Good afternoon. Very interesting presentation, Prof. I'm wondering about the substitute that you alluded to. In terms of having a higher proportion of potassium chloride. But from purely a palate perspective, a taste perspective, would there be a difference? Would somebody be able to discern that this has less sodium than the quote-unquote normal sodium chloride?
Yes.
I'm thinking about the acceptability eventually.
So that has been studied in other populations. We would, of course, need to do some local assessment to see. So they have different combinations of the low sodium salt. So you can have a 50-50%, you have the 75-25, you could have other combinations. What they've found is that the 75-25 is about where people they get the good level of acceptability. So foods prepared with that 75-25, a lot of persons were not able to differentiate between the two. Another thing that is done in terms of using the potassium-enriched salts is that they sometimes add taste enhancers to ensure that the palatability and acceptability is there. But it has been studied, and the studies have shown that using these salt substitutes results in significant reductions in stroke as well as other cardiovascular disease. So it has been studied clinically. It is how do we get this implemented within the local context. And we believe that by conducting this study using implementation research strategies, that this will help us to show, first of all, that it is feasible, and then, of course, to help to promote this as a policy direction to address the challenges that we have.
Okay. Thank you. We have another question. Yes, go ahead.
To what extent have you considered the use of Celtic or pink Himalayan salt, which have more trace minerals in them, including potassium, which can be healthier alternative to table salt?
Yeah, so the issue of using sea salt, Himalayan salt, and so forth is something that is highly debated. So the first thing to recognize that it's still salt. There may be some advantages. in terms of the coarser texture, etc., means that persons will actually use a smaller amount. So you may end up with less sodium. But if you're going gram for gram, the net effect is going to be similar. I'm not sure about the other mineral contents for the Himalayan salt, so that is something that we would need to study. But what I want to say is that I don't want persons to get comfortable to say that I'm using sea salt, I'm using Himalayan salt, so I'm fine. I think we still have to reduce net salt intake. But these are worthy considerations if we are going to reduce the total amount of salt.
Okay, we have, yes, go ahead.
Yes, there's too much salt in most chips, even when they mark lightly salted. Will there be fines imposed to encourage manufacturers to comply?
All right, well, I am not the one who implements fines. So the WHO does recommend financial, or what is the word I'm looking for, tax measures as one way to look at promoting healthier eating. So that's a strategy that has to be discussed and implemented at the government level. One of the things, though, that I want to point out again is the importance of reading nutrition labels, because sometimes the things that taste salty actually contain less salt than many others. So one of the things I remember, it was one of our professors that mentioned that the ketchup that we get has more salt than the fries. The fries taste salty because the salt's on the outside. The tomato ketchup has the salt in it, but it is hidden. So let us be a little bit more careful and actually read the labels, because one would be surprised to think that you are swapping, lightly salted banana chips for 2 slices of bread, and that bread may actually contain more salt than your banana chips.
Okay, thanks. And the last question is, have you and your team of researchers considered sample and analyzing meals from the menu of these restaurants for better data samples?
Yes, so the short answer is yes. For that, though, we need research funding. The funding that we got for this study did not allow us to do sampling. So we will hope, having established this, that we'll be able to write additional grants and we'll receive funding to be able to do samples so that we can have a better understanding as to the food landscape.
Okay, thank you. That's all.
Okay, thank you, everyone. And thank you, Professor Trevor Ferguson, for a superb presentation. Let's give him a what? Louise Bennett applause here and online. And at this time, we will now break for a commercial. Stay tuned and see you after lunch. Bye-bye.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the
Check.
and associations with the socio-demographic and health factors among Jamaican adults, also from the Jamaican salt consumption study. So please give her a what? Louise Bennett applause, and as she makes her way. Thank you.
Afternoon, everyone. Thanks, Dr. Davidson, for that introduction. So I'm going to be following up on some of the work that Prof. Ferguson just talked about. And I'll be speaking on the accuracy of spot urine as a measure of dietary sodium intake in Jamaicans compared to 24-hour urine sodium collection, and it's a validation study. So as Prof. Ferguson has just outlined, we could say, and we should know, hypertension is a global health concern with 1.28 billion adults between 30 and 79 years old who are affected. The prevalence of hypertension in Jamaica is approximately 33.8% for those who are 15 years and older, and this is from our Jamaica Health and Lifestyle Survey 3. One significant contributor to hypertension is high sodium consumption, and diets high in sodium can lead to increased blood pressure, which increases the risk of heart disease, stroke, and other health complications, as aptly outlined by Prof. Ferguson. Accurate estimation of population sodium consumption is a vital component to the public health response to hypertension. WHO recommends that populations reduce sodium consumption by 25% by 2025. So when we talk, we've heard of what the consumption levels of sodium is in the Jamaican population and globally. And one thing we have to bear in mind is how are we estimating these rates? So estimation of dietary sodium intake can be via the 24-hour urine sodium excretion, which really is a gold standard method for sodium consumption assessment. Approximately 90% of sodium consumed is excreted in the urine. It's challenging to accomplish because in large population-based studies. One of the other modes of estimating dietary sodium is through spot urine estimation, which are the results that Prof. Ferguson was used to do the estimates that Prof. Ferguson spoke to. The other mode of estimating dietary sodium is through dietary sodium assessment, which we're not going to be speaking to this afternoon. So when we're looking at estimation of urinary sodium excretion, which is a proxy for dietary sodium intake, the 24-hour urine sodium excretion, all urine passed in 24 hours is actually collected in a bottle. Sodium excreted in 24 hours is determined through laboratory analysis. It's difficult to complete by any one of us who have actually tried to do a 24-hour collection. But the good thing going for it is a more accurate measurement for daily sodium consumption and accounts for the variability of sodium consumption as well as hydration status. When you're looking at the spot urine estimation, it's a single urine sample at any time during the day. The sodium is excreted over 24 hours, actually estimated using a formula. It is easier to complete and much less cumbersome. But the drawback is that it is less accurate measure of daily sodium consumption, and it really does not account for the variability in sodium consumption as well as hydration throughout the day. So, for example, if you consumed a meal that is high in sodium and then you did an immediate collection, it would then reflect a high sodium consumption as compared to if you had a low sodium diet and then you did a collection, then it would have a lower estimate. So that is why the 24-hour collection is a more the gold standard. So really the objective of this presentation is to assess the accuracy of the spot urine sodium estimates as a measure of dietary sodium intake using the PAHO as well as the Intersalt formula compared to the 24-hour urine sodium collection. So very briefly our method. So this is part of the Jamaica Salt Consumption Study, which is a national survey of 60 enumeration districts in Jamaica. The validation study, participants were recruited from the first set of electoral districts in Kingston and St. Andrew region, where we targeted 120 collections. We obtained 109 samples and we're presenting the data for 60 paired samples that were analyzed. The inclusion criteria for analysis was a 24-hour collection of volumes more than 400 mils. Collection times are between 22 and 27 hours, and the spot urine collection was done within 72 hours of a 24-hour collection. So these are the formulae that Prof. Ferguson had just shown. So it's just to say that we did measured sodium from a 24-hour collection, and then we estimated spot sodium from either WHO PAHO formula or the Intersalt formulae. So for statistical data analysis, we're using descriptive analysis, where we looked at sex-specific and total sample summary estimates for both demographic, biomedical, as well as sodium intake variables. And we're doing assessment of the reliability and the agreement between the 24-hour collection as well as the estimated sodium from the formula. So we're going to be using paired t-tests, correlation analysis, as well as the kappa statistics. So the paired t-tests really look at the mean sodium excretion from the 24-hour urine collection that is compared with the sodium estimation using the WHO PAHO formula as well as the Intersalt formula. We'll also be using correlation coefficients, where we're looking at the within pair differences and within pair means for both the sodium excretion estimated from the WHO PAHO formula compared to the 24-hour collection, and we're looking at the sodium estimation from the Intersalt formula compared to the 24-hour urine collection. So for the kappa statistics, what we're going to be doing is that we assess whether persons classified as having high intake of sodium compared to the excretion using the 24-hour were similarly classified as high excretors using the WHO PAHO formula as well as the Intersalt formula. So very quickly for some of our results. So for the baseline characteristics of the participants of the sample, the mean age for both males and females was 49 years, and had significant lower body mass index in males compared to females, but the age as well as the blood pressure measurements were actually similar in both males as well as females. For the summary statistics, what you want to have here, for when we did lab analysis, the spot urine sodium consumption was 2,875 milligrams per liter, and the 24-hour sodium concentration was 2,626 milligrams per liter. When we're looking at the summary statistics, when we actually did the estimates, so when we looked at the 24-hour urine collection over a 24-hour period, overall, the 24-hour urine collection estimated sodium excretion to be 2,564 milligrams per day. The WHO PAHO formula estimated it to be 2,419 milligrams per day, and the Intersalt formula estimated it to be between 2,801 milligrams per day. So as you can see, looking at the trends, the formula do give different estimates, although when we did statistical analysis, they were not significantly different. When we're looking at high sodium excretion, the 24-hour urine collection classified 65% of the people within the population as excreting high, have a sodium intake of more than 2,000 milligrams per day. The WHO PAHO formula estimated it as 55%, and the Intersalt formula estimated it as 81.7%. So we can see that there are some differences when compared, when we're looking at WHO formula, the Intersalt formula, as well as 24-hour urine collection. So it's very important when we're looking to give estimates or changes in sodium excretion in trends in our population. So when we looked at the agreement, the WHO PAHO formula and the Intersalt formula compared to the 24-hour urine collection, the mean difference in the sodium intake was not significantly different from zero. So the estimates, what we're saying is they were similar. So when you compare to the WHO formula as well as the PAHO formula, we would say that they were similar enough, although when you look at the absolute values, they look to be different. When we looked at the classification of sodium dietary intake, the WHO formula, PAHO formula, compared to the 24-hour urine collection, we saw that there was poor agreement, and the Intersalt formula, there was fair agreement when we looked at the kappa statistics of 0.2 for the WHO PAHO formula and 0.48 for the Intersalt formula. So when we look at the repeatability of the agreement, we saw the WHO PAHO formula had poor repeatability. So this means the difference from the 24-hour urine collection increased as the mean increased. And when we looked at the Intersalt formula, it had fair repeatability, where the difference from the 24-hour collection did not increase significantly as the mean increased. So the main findings from our study was when you look at the 24 dietary sodium intake from the WHO PAHO formula and the Intersalt formula were compared to the 24-hour urine collection, The mean differences were not significantly different from zero. The agreement in classification of high dietary sodium intake was poor to fair, and the Intersalt formula values were more repeatable than the WHO PAHO formula values. So in conclusion, at the population level, either the WHO PAHO formula or the Intersalt formula may be used to estimate means or the averages for dietary sodium intake as an alternative for the 24 collection. And with the 24-hour collection as a gold standard, there may be misclassification of individuals for high sodium intake when the formula values are used. So really what that means, at a population level, we can use either the PAHO formula or the Intersalt formula for population estimates for sodium consumption. But if we were to look at the individual estimates, so for example, if you wanted to look at what my sodium consumption on a day-to-day basis was, neither one of these formula would be good at an individual level. Thank you.
Boy, I think it must be deafening. I think we need another round of applause. Yes? Get the energy back in the room. Apologies. Dr. Bennett presented on the accuracy of spot urine sodium as a measure of dietary sodium intake in Jamaicans compared to the 24-hour urine sodium excretion. And that was a validation study. So another excellent presentation, and our final presentation for this session will be done by Professor Trevor Ferguson, who will return to discuss the frequency of high salt consumption and associations with the socio-demographic and health factors among Jamaican adults. And again, another element of the Jamaica salt consumption study. So please give him a round of applause. He's been really fantastic today. This is the third presentation. Thank you.
Right, so good afternoon again. Final leg. All right, so here we, thanks Dr. Davidson, and good afternoon everyone. So we're going to talk now about the frequency of high salt consumption or high salt foods, and the association with socio-demographic and health factors among Jamaican adults. So most of us are familiar with the concept of the nutrition transition, which has resulted in increased consumption of ultra-processed foods that are high in fats, salt, and sugars, and reduced consumption of minimally processed foods. Many people are choosing pre-prepared, pre-packaged, ready-to-eat, highly processed foods that are manufactured outside of the home and are of lower nutritional value. Now, ultra-processed foods are believed to be a major contributor to adverse health outcomes. Now, with increased development and industrialization, there has been some improvement in economic performances globally. However, while income and purchasing power have increased, leisure time has decreased. And this has led to limited time to prepare foods at home. Of course, these will be foods of higher nutritional value. And the increased availability of pre-prepared foods has further compounded the problem, resulting in further reducing the consumption of home-prepared meals. So we have shown previously that, of course, high salt consumption is associated with adverse health outcomes, but overall dietary quality and health are greatly impacted by these changes in disease patterns. And we have recently documented high sodium consumption and low potassium intake in the Jamaican population, which may be due largely to high consumption of ultra-processed foods as well as high salt foods, but we have limited data on these occurrences. So the objective of this study was to estimate the frequency of high salt foods consumption among Jamaican adults and evaluate association between socio-demographic and health factors. So again, this was a cross-sectional study from the Jamaica Salt Consumption Study. We collected data in 2022 to 2023. Participants were 18 years old and older and were from 60 nationally representative enumeration districts. Trained interviewers collected information on a 60-item food frequency questionnaire, of which 39 items were classified as high salt foods and 21 items classified as low salt foods. And this classification was done by our nutritionists on the team. We then created scores to estimate the daily intake of high salt foods and low salt food items and categorize these into tertiles. So this is a list of foods that were classified as ultra-processed or high salt. We won't go into the details here, but of course, this can be shared afterwards as required. And we also have our list of minimally processed foods, which we can also share. So in essence, we looked at the frequency of consumption of each of those 39, as well as the 21 items that were included in the minimally processed foods. So with regards to our statistical analyses, we used Stata version 18. We estimated means and proportion for outcome and exposure variables and the various covariates. Then we assessed associations with age, sex, and socioeconomic status, as well as other health characteristics. For these analyses, we use multivariable, multinomial logistic regression to obtain odds ratios for the associations, and for these, we compared those in the highest tertile of high salt foods to those in the lowest tertile. The estimates were again weighted for survey design, and analyses were restricted to 952 participants who had complete data on the variables of interest. So looking at our results. So we had 952 participants, 578 males, 374 females. Mean age was 40.9 years. 26.4% had self-reported hypertension. 10.7% had diabetes, 11.5% had high cholesterol, 17% were smokers, and 30.7% had low physical activity levels. Now, in terms of the frequency of consumption of the various food items, so for high salt foods, we estimated that on average, persons consume 6.4 high salt food items per day, compared to 4.8 high salt food items per day. And this was higher in men compared to women for both the high salt foods and the low salt foods. Now, when we looked at the consumptions by age category, the frequency of consumption of high salt foods significantly decreased with age. There was no significant rural-urban differences. For low salt foods, again, frequency of consumption decreased with age, and for low salt foods, there was a higher consumption of low salt foods among urban residents. With regards to factors associated with high salt foods, again, this is looking at the men, and we're comparing those in the upper tertile of high salt food consumption to those in the lower tertile of high salt food consumption. So significant factors associated were age, odds ratio 0.94, suggesting that as persons got older, they were eating less high salt foods. Those with higher levels of education, for high school education as well as more than high school, were more likely to consume high salt foods, with odds ratios of 2.07 and 3.02. And men who currently smoke tobacco were also more likely to consume high salt foods. Among the women, again, age was significantly associated in an inverse direction. So older age meant less consumption of high salt foods. Women who were overweight or obese had higher odds of high salt food consumption with an odds ratio of 1.8, as well as those with more than high school education with an odds ratio of 2.98. Women who had a history of high cholesterol levels were less likely to consume high salt foods. So our main findings, Jamaicans are consuming approximately 6 high salt food items per day compared to 5 low salt food items. High salt foods is lower among older persons, but higher among those with higher education. Men who smoke and women with obesity were more likely to consume high salt foods, while women with high cholesterol were less likely to consume high salt foods. So we recognized in terms of one strength of this study, we used survey weights to ensure that the data were nationally representative. A limitation, the study only addressed the frequency of consumption. We didn't have data on quantity of food consumed, and therefore we cannot estimate the quantity of sodium consumed. However, we can conclude that most adult Jamaicans have high consumption of high salt foods, and public health interventions are needed to educate the population on healthy food choices and to increase the availability of healthy options and encourage more home-prepared meals. These are the references. Thank you very much.
Three excellent presentations, especially post-lunch, talking about sodium consumption. So at this time, we invite questions into the room and online. Go ahead. Thank you.
Okay, so question is sodium citrate a good alternative to sodium chloride?
I'm not very sure of that. I don't know if we wanted to have the nutritionist get sodium citrate. I've not seen that recommended in the literature.
Probably not, because sodium citrate is actually quite sour. Right, so no.
Okay, another one. Did you consider comparing high salt consumption with the occurrence of mental health concerns?
So we haven't looked at that directly. I think we do have data. I mean, I'm not 100% sure whether or not persons reported depression. We would have to double check our questionnaire to see if that is there. But yes, that's something that sometimes, comfort food eating that. And if we don't have it now, we can probably look at it in a future study. Mm-hmm.
Any other questions? Yes, go ahead.
Okay, thank you so much for this excellent presentation. My question goes to both of the presenters. The first one is concerning the two tests, the PAHU test, and the other one was Intersalt. Now, if we use one of those tests, can we say that the validity of that test, can the validity of that test be done, or it has to be the two for us to be able to say what is okay, what is acceptable?
So, from our study, so when you're estimating sodium consumption or excretion, there are several formulae that are available out there, and these are only two. These are the two popular ones that are. So we wanted to check for both of them, both the PAHU and the Intersalt, to see if either one is more comparable to 24-hour urine collection. We have further work that we're going to do to see if we have to work on it a little bit further to see if we would recommend one versus the next, or combining both of them together.
Okay.
So that's what we'd say to that.
All right. Thank you. Mm-hmm. The next question for...
So, in essence, from what we have shown, so when we look at the mean sodium intake at the population level, whether we use the Intersalt formula or we use the PAHU formula, it was not significantly different from that obtained from the 24 hours. So either can be used. So you don't have to do both. But what we saw was that PAHU levels were a bit lower and the intersalt was a bit higher, which is why in my report we use the average of the two. So what we will be doing is to do further statistical analyses to try to assess whether or not that holds, to say, is the mean of the two better than doing one? But if you have one formula and you're using that at a population level, it is okay. But at the individual level, you may end up with misclassification. So in essence, at the population level, the errors cancel out, so to speak. But at the individual level, there's probably too much error.
That's why I was asking to me both. Thank you. Then the next question is, you said something about the women who had high cholesterol or individual with high cholesterol had lower salt intake. All right. Is it as a result of their diagnosis that they began to be conscious to have reduction in their salt intake, or it was just by chance?
Well, so in this case, for these analyses, we looked at persons who, this is based on doctor diagnosis of high cholesterol. So, of course, you know that if you're diagnosed with high cholesterol, you're going to be instructed by your doctor to go on a low cholesterol diet. Now, going on a low cholesterol diet will eliminate a number of the high salt foods. So it is likely that this is a result of persons being on a low cholesterol diet and therefore eliminating some of the high salt foods. So that's the most likely reason why we saw that association.
Okay, thank you. Now, based on this study, will it be okay to indicate or make a statement that persons who go for regular checkup should do a regular cholesterol and all the tests on the visit, just to be sure that you don't send somebody home who would have already been on a high cholesterol level or any of the high salt? Should it be something we do regularly
So
as
there,
a routine test?
yeah, there are guidelines in terms of screening for the health condition. So we recommend an annual check for high cholesterol. So once per year usually would be fine. We recommend, of course, that persons also be checked regularly for high blood pressure. Persons should be screened for diabetes, etc. And those are the ones that are recommended for screening, and we would expect annual screening for adults. In terms of, there isn't a recommendation to assess individual level salt consumption, but of course we're going to advise everyone to have a healthy diet, and that healthy diet will include significantly reducing the consumption of processed foods and high salt foods to result in better health. So yes, we would want persons to be reminded about a healthy diet, although at the individual level, doing your, checking your urine for sodium is not something I would recommend, but definitely annual checks for cholesterol, diabetes, kidney problems, etc., and screening for high blood pressure is recommended for all adults, plus a healthy diet.
Thank you, sir. Not to keep you on, just give me one recommendation for a healthy society based on your knowledge of the one good recommendation for a healthy Jamaican population. 2-point-something million. We all want to be healthy. What should be done? Thank you.
Well, if we eat more home-prepared, natural-type foods, we would be better off and more healthy. So, she said one. So, a focus on home-prepared as opposed to processed and foods prepared outside the home. So let's get back to the dining table with mother cooking around the fire.
All right, thank you. And we do have another question. We have one more. Yes, go ahead for me, please.
Okay. What can be done to have the salt content of high salt foods decrease, and are manufacturing companies of the high salt foods aware of these studies that are being performed?
All right, so I guess some of the answers is contained in the question. So, so first of all, we spoke about what we can do at the individual level. So in our meal preparation, we want to reduce salt when we're cooking. We want to discourage adding salt at the table completely. And of course, to use less processed foods, read the labels, etc. So more home-based, low-salt foods. In terms of the manufacturers, I think they're aware, at least at the superficial level, there may not be a strong commitment. Some manufacturers do produce low-salt items, or you'll see lightly salted, reduced salt. So there are some efforts that are being made, but that really needs to be quadrupled. What is being done now is maybe just the very minimal, but we need to work with industry to produce healthier foods for the population, and that requires a whole of government, whole of society approach to get that. So reformulation, reduce salt, reduce fats, reduce sugars definitely is recommended.
And I think I'd like to add to that to say part of it is as well as our responsibility. So what we also have to do is maybe do as well. So people to read the labels and so. So it's not only on government, but we have our part to play as well. So it's part of an education, I think.
Okay, any other further questions? Okay. So at this time, I'd just like you to thank our presenters, Professor Trevor Ferguson, Dr. Nadia Bennett. Please give them a round of applause, Louise Bennett. No, that's on thank you, and Pia. So we have come to the end of a very excellent session, obviously with too salt, yes. And so we're moving to the commercial break. I hope you took away something from this session. Thank you, everyone, for listening. Oh, we have a presentation to make? Yes, go ahead.
Good afternoon, everyone. It would be remiss of us to not recognize all the persons who contribute to this conference. This came out in our opening ceremony this morning with respect to all the stakeholders. And one of the members of the team are our moderators. And so we want to especially recognize Dr. Tamu Davidson and thank her for moderating this session. We also wish to, I see that Prof. Ferguson is leaving, but we also want to especially recognize Prof. Ferguson in terms of the feature presentation that he gave this morning. So we want to just give him yes. For those who didn't hear online, somebody is saying check it for sodium. At this time, we can go to the commercial break.
What you got? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in at the hospital.
So why you never tell me?
I didn't even know. I not rest. A peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them a tell me say if my breastfeed.
As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop for it because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop for it.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back to life. Zoom in.
Good afternoon, ladies and gentlemen. So welcome to our scientific session 3, Surveillance and Laboratory Studies. My name is Christine Ehikamenor from the National Sequencing Facility at the National Public Health Laboratory. So this is our last session for this afternoon, where our presenters will be doing presentation on their abstracts. We're celebrating 15 years of research excellence, and we will close out this afternoon with 4 interesting research presentations. We will have 2 presentations, and then we'll move into our question sections, and then we'll have the 2 other presenters followed by the question and answer section. So I'll introduce the first 2 presenters. We have Dr. O.J. Gordon. He's a product of the University of the West Indies. He completed a bachelor's in the natural sciences before embarking on a career in medicine after a short time as an educator. Having received his DM in anesthesia and intensive care and completed a fellowship in critical care, he is now a consultant at the University Hospital of the West Indies, where he has a special interest in advancing critical care through education and establishing quality improvement systems. Dr. Gordon. Also, we also have Mr. Simoy Noble. He's a dedicated microbiologist at the University Hospital of the West Indies. The microbiology department specializes in zoonotic diseases, arbovirus surveillance, and pathogen discovery. He's committed to advancing data-driven vector control strategies and promoting citizen science. Mr. Simoy's work aims to provide actionable insights into the emergence and prevention of infectious diseases. Mr. Noble is a firm believer and follower of the Lord Jesus Christ and believes, as recorded in 2 Corinthians 3, verse 5, not that we are competent in ourselves to claim anything for ourselves, but our competence comes from God. Welcome our 2 presenters.
Good afternoon, everyone. Thank you for having me, and I'd also like to thank my co-researchers, Dr. Eka Metalor and Dr. Thomas Rodriguez, for assisting me in this study. So we can get to the meat of the matter. So, as we are all unfortunately aware, the COVID-19 pandemic began in December of 2019. And to date, it has taken the lives of millions of people across the globe. Now, as for Jamaica, we recorded our first case in March of 2020. Now, of those people who become infected with the SARS-CoV-2 virus, less than 15% or so become critically ill, which involves severe lung injury, multi-organ dysfunction due to the underlying viral sepsis. But quite importantly, of those who do become critically ill and require mechanical ventilation, we see mortality rates as high as 88%. So this is certainly a serious matter. Now, as a type A hospital, the University Hospital of the West Indies was one of the designated primary referral centers for critically ill COVID-19 patients who may require ventilatory support. From the period of March 2020 to February 2021, we admitted approximately 86 cases of critically ill patients who required intensive care. One of our intensive care units, ICU A, became the designated COVID unit where we isolated these patients and where we administered treatment to them. During the course, within the first year of the COVID pandemic, during treating these patients, we noted informally that we were seeing a high number of septic cases and that these patients had culture-positive bacteremia in the unit, meaning that we took blood cultures and we were getting back bacteria growing in these patients. And also informally, we noted when we got back these results that these patients had significant and dramatic deterioration in their clinical status. Now, we as doctors, we strive to work on evidence-based medicine. So just looking at something and say, boy, it seemed like this, that don't work. We wanted to do actual research to see, is what we are seeing true? Was the increase we are seeing real? Was it affecting our patient outcome? And what were some of the potential causes for this increase? So we designed this study. We wanted to objectively determine the potential effect of COVID-19 on the bacteremia and on our patient outcomes. So, what were our aims? We wanted to compare the prevalence and the causative agents of this culture-positive bacteremia, bacteria growing in the blood, between patients admitted the year prior to the COVID-19 pandemic and the year immediately starting after the COVID-19 pandemic. And then we did further sub-analysis looking during the COVID pandemic at patients who had COVID and patients who did not have COVID. And in comparing these, we thought that would be the best way to determine what was actually going on. We also wanted to look at our outcomes. So we compared the mortality outcomes between the COVID-19 and the non-COVID-19 patients with bacteremia. Research methods, of course, we got our ethical approval, and what we conducted was a retrospective, single-center cohort study at the University Hospital of the West Indies. Our study population was all adults admitted to the University Hospital between March of 2019, which was the year prior to COVID, all the way to 1 year after the start of COVID in Jamaica, which was February 2021. Now, we looked at comparison between the prevalence, the causative agents, and the mortality between these two cohorts. So, just to make it clear, cohort 1 is those patients admitted the year before COVID. Cohort 2 are those patients admitted the year after the onset of the COVID-19. So when you hear me referring to that, that's what I'm talking about. COVID-1 before, COVID-2 the year after. So what did we find? One of our primary things we were looking at was what was the prevalence of bacteremia. And we found very clearly that what we had observed was in fact true. The prevalence of bacteremia in the year after the onset of COVID pandemic was significantly higher than in the year before, and the figures there show it. We have 28% prevalence of bacteremia after COVID as compared to 17%, and that was significant. P-value, very, very small. The other thing that we looked at was in our sub-analysis of cohort 2, we were looking at those people who had COVID and those people who did not have COVID. And within that, we saw that bacteremia was again significantly improved, almost double in fact. So you can see here a prevalence of 46.5% as compared to 22.1%. So very significant there. When we're looking now, we looked at the prevalence of the most common microorganisms, Enterococcus, cons, Pseudomonas. Now, a bunch of names which might mean something to you, which might not mean something to you. But the main point for you to take home is that when we then further categorize these organisms, we could see there was almost an equal balance between gram-positive and gram-negative. Significance being that that's different from what was being seen in the developed world where they had a predominance of gram-negative organisms. Looking back now at our comparison, when we looked at these organisms, as you can see in red, that there was a significant increase in the amount or the prevalence of cons in those patients during COVID as opposed to before COVID. Significant there. The other thing that was seen is then when we compared those patients who had COVID as compared to those patients who did not have COVID, we again see that there was a greater prevalence of bacteremia again. Again, cons and also Enterococcus was found to have a greater predominance in our COVID patients as opposed to our COVID patients. So this difference here does give us an idea that, yes, there was increased bacteremia because of COVID, and the most likely causative organism was with cons, coagulase negative staph, and Enterococcus species. When we looked at our outcomes, what we saw was not in keeping, and it was quite disappointing to me, because you would think, all right, we've confirmed that there is more bacteremia. We've confirmed that it's likely due to cons and whatnot, so we would think that our outcomes should be worse. When we looked at our outcomes, which was 30-day mortality, 60-day mortality, and the mean length of stay, while looking at the actual numbers, 30-day mortality was higher in our post-COVID patients. That's our 51% versus 35%. When we did the actual analysis, the p-value was not found to be significant. It was close, 0.06, but did not achieve significance. The same could be seen with 60-day mortality, where again, 0.1 did not meet significance. And our mean length of ICU stay also did not meet significance. What could account for this? I do have to admit that we did find restrictions in terms of getting our mortality data, so there was missing data. And so I suspect that that may be the reason why what we were expecting, we did not meet the threshold of significance, even though we were trending towards it. So in conclusion, what can we say? We can absolutely say that what we observed was true. The prevalence of bacteremia in the year after the onset of COVID was significantly higher than in the year before. The prevalence of bacteremia was higher in those patients who had COVID as compared to those patients who did not have COVID. And we also noted that there was a change seen in the predominant organisms after COVID as opposed to before COVID, notably a large increase in the coagulase negative staph. But however, there was no statistical difference in 30-day mortality, 60-day mortality, and length of ICU stay. What accounts for what we're seeing here? This result was not isolated. It was seen in other studies across the world, and the reasoning fell into two camps. One was that because we were unused to working in PPEs, there was a disruption in our flow. We had staff moving around the place. Things were not as they used to be. There was a fall off in our infection control procedures. The other thought was that it's due to the treatment that is used for COVID, which involves steroids, interleukin-1, interleukin-2 antagonists, which depreciate your immune system, or maybe some direct pathological effect of COVID itself, which was causing us to see this increased prevalence of bacteremia. So clinical applications, implications. Yes. So to reduce the risk of contamination, staff should receive training in aseptic protocols in PPE and in the placement of central lines as well. Where possible, sampling for blood culture should be done by peripheral venipuncture as opposed to using indwelling catheters. And for initial gram-positive Cocci results, i.e. your cons, given the higher rates of contamination in COVID-19 patients, but also catastrophic results if it's not treated and it's a true infection, we need to establish protocols with microbiology to help distinguish contaminants from true bacteremia. And we need periodic assessment in the ICU, and a large multi-center study is needed to determine if what we're seeing is true or due to contamination. Thank you.
Thank you, Dr. Gordon. Very excellent presentation. We will now go to Mr. Simoy Noble.
Good afternoon, everyone. So I'll be presenting on some preliminary results, and the title of my speech, my talk will be Surveillance, Mosquito Species Diversity and Distribution in 3 different ecological niches in Jamaica. So, arboviruses are responsible for many important vector-borne diseases of clinical and veterinary importance. Arboviruses, also called arthropod-borne viruses, are vectors that are transmitted by ticks, mosquitoes, and midges. Mosquitoes account for 700 million infections yearly and about 1 million deaths annually. There is also a rapid increase in terms of dispersal and also the establishment of these vectors in different and new ecological niches. Additionally, there is a frequency of incidents where re-emerging mosquito-borne viruses are concerned. One in particular is the Oropouche virus that was first identified in Trinidad and Tobago in 1955. Of late 2023, early 2024, there have been several outbreaks in the Western Hemisphere, which has caused several deaths and miscarriages. So vector-borne disease accounts for 17% of all global infectious disease, with pathogens transmitted by mosquito one of the largest contributors to this burden. This affects the productivity and also places a strain on the healthcare system in these endemic areas. To note, dengue alone, dengue fever risk alone accounts for 3.9 billion exposure per year, and this number is expected to increase annually. So why study mosquito? So mosquitoes are important vector. We can all agree that they are a nuisance. However, they are competent agent where transmission of arboviruses are concerned, such as West Nile virus and the malarial parasite. There are also, one fact that is also overlooked are they are key pollinators in the environment. There are a total of 3,500 mosquito species to date, where 2.5% of these species are competent vector for human disease-causing pathogens. They are adaptable, where their blood-feeding preference are concerned and their egg-laying status is. So, for example, some mosquito will prefer to lay in containers, where some prefer to lay in tree holes and even in animal footprints left in the soil. Mosquitoes are distributed globally. They are present on all continents except for Antarctica. So with our increasing interconnectedness, which facilitates ease of travel, this also is same for the vectors and also the pathogens they transmit, where trade is concerned and travel. Increasing global temperature is also a big factor that influences disease transmission, where it expands the geographical range of these vectors. It prolongs the transmission season. It increases the replication of the virus in the mosquito, and also it lowers or shortens the mosquito life cycle. With encroachment into these habitats that mosquitoes call home, humans are more exposed to these vectors, and as such, to the pathogen they carry. So this diagram, I just want to highlight the interconnectedness of these factors which contribute to mosquito disease spread. And the two factors I'll be looking at are the vector and the environmental niche. So the benefits of surveillance. It serves as an early detection system for outbreaks. So rather than being reactive, we are proactive. It propels data-driven control measures, and it informs public health policies. So the aim of this study is to assess the presence and diversity of mosquito species in different ecological niches in Jamaica. So to begin, the sites were selected was due to convenience, the safety of the traps, and accessibility. So BG Sentinel traps were used. They were baited with dry ice, and they were set up from dusk to dawn. Mosquitoes were transferred to the lab on cold chain, where they were sorted using a stereo microscope and taxonomic key by Belkin. They were sorted based on sex, species, date, location, and blood-fed status. Blood-fed females were then sorted and stored for future analysis, and non-blood-fed females were then sent for downstream viral analysis. Also to note, morphological identification was supplemented by molecular ID as well, using PCR and sequencing. So this is just a layout of some of the areas that we sampled. So for the rural areas, we sampled in Petersfield, Westmoreland, Myersville, St. Elizabeth. For the wetlands, we sampled at the Caribbean Coastal Area Management, that is in Clarendon. And for the rural, we sampled in Mona and Walkerswood, St. Anne. For the results, a total of 7,620 mosquitoes were collected between September 2022 and December 2023. Preliminary results indicate variation within mosquito species within the different ecological niches. A total of 8 genera were identified, namely Aedes, Culex, Anopheles, Dinosaurites, Sorapher, Mansoni, Wyamaya, and Toxorhynchites, with Aedes, Culex, and Anopheles being targeted genera during vector control programs. Culex nigropaupus and Culex tenorhynchus dominated bird resting shelters in rural areas and wetlands, respectively, and Culex superfasciatus dominated rural areas. Mosquito diversity was the greatest in forested areas, and this was expected due to the abundance of animals they can feed on, and also the climate and temperature that is ideal for their survival. So this table is basically showing the breakdown of the different species that we have found in the different ecological niches. To note, Aedes and Culex were found in all of this environment that were sampled. However, the species that they were different within each niche. For example, forested areas, we saw Aedes walkeri Orites, and Grabhan, which are all endemic to Jamaica. In the wetland areas, we saw Aedes tenorhynchus, which are competent vectors for several pathogens. And in the rural areas, we saw Aedes aegypti, which everybody knows. So I would like to point out that Aedes aegypti was only found in the rural areas, and that was expected, as it is an anthropophilic vector, which means it likes to be around humans. And as such, we normally see them in urban and rural areas. So for conclusion, this study highlights the diversity and distribution of mosquito species across 3 ecological niches in Jamaica. The finding underscores the importance of niche-specific mosquito surveillance and to improve vector control and early detection system, and to help support public health efforts in disease prevention. For future work, we hope to conduct a viral analysis on the non-blood-fed females and also conduct meal analysis on the blood-fed females to see what they are feeding on within the respective ecological niche. Here are my references. I'd like to thank God. My supervisor, Dr. Sandy Ford, Nadia Curry, Maria Goldin, the NEPA Forestry Department, and the Department of Microbiology, the Royal Society of Tropical Medicine and Hygiene grant, and the Global Infectious Disease Training Program Award. Thank you.
Thank you very much, Mr. Noble. That deep education about mosquitoes. We're moving now to our questions. Are there any questions in-house or online?
Hello. Good afternoon. Excellent info, Dr. Gordon. Read the findings in COVID situation. If the findings were similar to those international, what was or were there causative factors responsible for the situation?
Hello? Yes. So as I mentioned briefly at the end of the presentation, they found in multiple areas the same findings that we had of this increased bacteremia. But the decision was divided. There was no consensus. There were one camp who was saying that it's because of disruption of our normal processes that we're having increased contamination. That was one thing. Then the other camp was saying, no, this is an actual pathological process which is happening. Because of COVID, we're seeing true bacteremia. Based on my findings, I fall into the latter camp, because while there was an increase in the amount of coagulase negative stuff, which under normal circumstances we would normally say is a contaminant, we had strict processes in guideline, in coordination with our microbiology to screen out the contaminants. And so we are convinced that a number of these were true contaminants. And we also saw a significant increase in Enterococcus as well, which is not a contaminant. So I believe that we were seeing a true increase of pathological bacteremia in these patients, as opposed to just contamination because of a breakdown in our normal processes.
Okay, thank you very much.
Go ahead. Will it be okay to state that within the COVID there was bacterial infection? Therefore, utilizing antibiotics would have been more effective as part of the treatment option.
So this finding would definitely point in that direction. Limited time to present everything, but there was mention in my research of the fact that a survey of all the various protocols throughout showed that there was a move towards just empiric antibiotics in your critically ill COVID patients, assuming that there will be a high risk of co-infection, secondary bacterial infection in these patients.
Thank you. My next question will be that right now, if you see a COVID patient, would you suggest alongside the treatment that they give antibiotics?
Right. So we need to separate just our COVID. Remember, everybody gets SARS-CoV. Only 15% become critically ill. So where I work in intensive care unit, 100%. If you come in and you are critically ill, I have a very low index to start you on antibiotics, even if I don't have a confirmed bacterial infection. But in your regular patient who just comes in might need to be in A&E or may need a few days admission on the ward, I think that would need further research to decide if that's something that's warranted.
Or could we just test them?
There's that, yes. Yes.
Okay, yes, thank you. Go ahead.
Clarity with the rural areas that you sampled. That was one question. And my second question was, what does classification of the different types of mosquitoes and the prevalence, estimating the prevalence, mean for dengue prevention?
So we can understand the different species that are present. We can now better understand the different areas that we can target. Not all mosquito species are container breeders. Some lay eggs in tree holes and so forth. So better understand their laying patterns, information on the different species present is important. So we can understand the different niches to target in terms of vector control measures.
Okay, thanks. And the rural areas?
You say you want clarity? So we selected areas based on convenience and ease of access. So these areas were, two areas we selected were Petersfield, Westmoreland, and Myersville, St. Elizabeth. And they were just, how we classify them is based on the fact that they had animal in the vicinity and so forth. So away from towns and busy.
Thanks.
Another question behind.
Thanks very much for the presentation. Informative. Dr. Gordon, I wondered, are the identification of the bacterium from the day one admission samples, or is it that these persons were probably progressive and you did second, a later onset? I'm trying to establish whether they may be late onset bacteremia or on presentation bacteremia.
Right. So in terms of the study itself, no distinction was made between the timing of the blood cultures, but I can tell you from experience working in the unit that the majority of these patients were patients who developed bacteremia subsequent to admission. So these would have mainly been hospital-acquired infections as opposed to infections that they came in with. These patients came in, initially had no signs of sepsis, developed sepsis, and then subsequently on screening with doing our blood cultures and various things, they were found to then have developed bacteremia subsequently.
And you're still more inclined to believe then that it's more aligned to a pathological process of COVID-19 infection as against contamination?
Yes.
Yes. Okay. And in relation to
Noble?
Noble, I just wanted to understand if your interpretation of the distribution of the different species, is it that we are seeing a different set of distribution in terms of the classification? Because from my recollection, it almost appears to be very similar, but there may be a difference in terms of volume.
So to begin with, the last major study that was done was in the 1970s by Belkin. So that needs to be updated. So one, we want to update the literature where that is concerned. Also, what we saw was kind of expected, or we still have to look for invasive species that may be present here that we don't know of.
So we need additional evaluations and studies.
Right.
Great.
Right.
Thanks.
Yes, this is a question for Mr. Noble. Wonderful presentations, especially for the mosquitoes in the rural areas. What would you recommend natural alternatives to manage their numbers?
So, as you can see, one of the species that we found in the rural areas was Egypti. Egypti, or they are container breeders. So what we try to do whenever we go into these areas is to inform the citizens of things that they can do. One, if they have containers that are present that has water, bring it over. And I've found that when you interact with the residents in those areas and let them feel a part of the intervention measure, it gives them a sense of purpose, and they are willing to continue in the future. So we're eliminating the containers, the breeding container sites, and also using personal protection, and also adding oil to the surface also reduces the number of these species.
Okay, thanks for that.
Okay, if there are no more questions, can we have a round of applause for our first two presenters? So I'll now introduce our third and fourth presenters. The first is Mr. Mario Goldin. He's a pre-doctoral student in the PhD pharmacology program at the University of the West Indies, and his research is focused on the controlling of the dengue vector Aedes aegypti. Mr. Goldin has a general background in pharmacology with specific training and expertise in animal-based research, as well as critical competencies in plant extractions, such as succulent extraction with serial solvent dilutions of essential oil extractions with the Clavenger apparatus. Though his research journey is still in its infancy, he's eager to make a positive difference on the scientific community. Ms. Valisha Leach, a proud past student of Rosse's High School in Lucy, has a bachelor's degree in microbiology. She recently earned a master's degree in medical microbiology and with a research component. Ms. Leach now works as a medical laboratory scientist at the microlabs in Montego Bay. She's passionate about research in antimicrobial resistance, particularly in Neisseria gonorrhea, due to the alarming rise of untreated infections. Please welcome our two presenters. We'll start with Mr. Mario Goldin.
Good afternoon, everyone. Today I will be sharing with you this brief presentation on the insecticidal activity of Jamaican Myristica fragrance oat essential oil against Aedes aegypti mosquitoes. Now, Aedes aegypti, commonly referred to as the yellow fever mosquito, is an important vector of several disease-causing pathogens, such as dengue virus. This mosquito has recently been implicated in the 2023 dengue epidemic, for which there was 8,180 reported cases of the disease and 6 deaths. Now, the Aedes aegypti life cycle consists of 4 distinct stages. Firstly, we have the egg stage, followed by the larval stage, and the larval stage consists of 4 different stages. We have the first larval, second larval, third larval, and fourth larval, or L1 through L4 for simplicity. Next, we have the pupal stage, followed by the adult stage, all 4 of which were targeted during this research. So at present, the only measure available in Jamaica to limit the incidence of mosquito-borne diseases is vector control. Now, vector control can be broken down into 3 main categories. Firstly, we have the environmental control, which involves elimination of possible mosquito breeding sites. Next, we have chemical control, which involves activities such as mosquito fogging, as well as the addition of insecticides to stagnant bodies of water, which cannot be eliminated. And finally, we have personal protection. And personal protection involves activities such as the use of insect repellent or the wearing of light-colored long-sleeve clothing. However, it must be noted that according to Francis et al. 2017 and Francis et al. 2020, current vector control strategies are being hampered, and this is largely due to the development of insecticide resistance in the Aedes aegypti populations across numerous parishes in Jamaica. As a result, there is currently an urgent need to identify alternative control agents for which plant-based therapies have been suggested. So for this research and presentation, I chose to focus on the insecticidal activity of essential oils. Now, an essential oil refers to a concentrated aromatic hydrophobic liquid containing the volatile constituents of a plant. In most instances, these essential oils are regarded as safe, and as it relates to the insecticidal activity of essential oils, numerous studies across the world have demonstrated that different essential oils possess insecticidal activity. However, these studies, as it relates to the Caribbean, have only been limited to Cuba and a lone study in Martinique. No documented study could be found in the literature from Jamaica. So for this research, I focus on the Myristica fragrans hot. Now, this plant, popularly known as nutmeg, is an evergreen tree in the Myristicaceae family. And as it relates to the insecticidal activity of this plant, several studies from different regions of the world has demonstrated that this plant does indeed possess insecticidal activity, particularly against the larval stage of Aedes aegypti mosquitoes. However, it is a known fact that plants from different geographical regions may differ in chemical composition and thus in activity. As a result, I wanted to investigate the insecticidal activity of the Jamaican variety of the Myristica fragrans essential oil. So this slide here shows a simple schematic of the methodology that was employed, which included first obtaining the Myristica fragrans seeds, followed by hydrodistillation of the seeds to derive the essential oil, and then this derived essential oil was bioassayed against all life stages of the laboratory Rockefeller Aedes aegypti mosquitoes, which were obtained from the Center for Disease Control and Prevention, as well as against a Kitchetown field strain, the L3 and pupae of that strain, which were obtained from the Ministry of Health and Wellness. Following all experiments, the data was then analyzed using GraphPad Prism version 9. Now, this slide here shows the 4 different bioassays which were done. For the ovicidal, larvicidal, and pupicidal assays, these experiments were adapted to 6-well plate and involved using 25 eggs for the ovicidal assay, 15 larvae or 15 pupae for the larvicidal and pupicidal assay, and mortality was observed at 72 hours and 24 hours. As it pertains to the adulticidal assay, 20 fully engorged female mosquitoes were used, and mortality was monitored daily over 14 days. Now, in the interest of time, I will only be showing the results for one of the larvicidal assay that was done, and that is against the most commonly targeted L3 stage, as well as the results of the adulticidal assay. Now, this graph here shows the log concentration response curve of the Myristica fragrans essential oil on both the lab and field Aedes aegypti L3 larvae. Now, what we see in this graph is that as the concentration of the essential oil increased, there was a dose-dependent increase in mortality, and an LC50 of 7.179 ppm was obtained for the laboratory strain, indicated by the blue curve, whereas for the Kitchetown field strain, there was a statistically significant increase in the LC50 to 15.82 ppm, resulting in a shift to the right of the dose-response curve. Now, LC50 here simply refers to the concentration required to kill 50% of the population. According to Camilla-Sara et al. 2007, essential oils with LC50 less than 50 ppm are considered highly effective. Thus, in both instances here, we can see that the Myristica fragrans essential oil was indeed highly effective. So this graph here shows the survival curve of the adult female Aedes aegypti mosquitoes, which were fed on a Myristica fragrans essential oil laced blood meal. Now, what we see in this graph is that for 100 ppm and 1000 ppm of the essential oil, the percent survival was decreased in a stepwise manner to 68.3 and 53.3% respectively. Whereas for the 3% DMSO negative control, no mortality was observed over the 14-day experimental period. Now, if we take a look at this table here, which shows a summary of the insecticidal activity of the Myristica fragrans essential oil against all the tested life stages of the Aedes aegypti mosquitoes, we can see that against the eggs of the Rockefeller laboratory strain, the essential oil displayed no significant activity. Whereas against the adults, as mentioned before, the oil was able to decrease percentage survival to 68.3 and 53.3% respectively. Against the L1 through L4 of the laboratory strain, the oil displayed potent activity, with the lowest LC50 value being obtained for the L3 stage. Against the pupae, which is a non-feeding stage, the essential oil also displayed activity, but at a much higher LC50 of 1090 ppm. A similar trend was observed for the Kitchetown field strain, where the essential oil displayed potent activity against the L3 larvae and also displayed activity against the pupae, but again at a much higher concentration than against the larval stage. So in conclusion, the Myristica fragrans essential oil lacked significant activity against the egg stage, but displayed a dose-dependent increase in mortality against the larvae, pupae, and adult stages of the Aedes aegypti mosquitoes. However, further studies are needed to decipher the exact insecticidal mechanism of action of the Myristica fragrans essential oil, as well as to determine the active constituent of the oil. So I would first and foremost like to thank God. I would like to thank my research supervisor, Dr. Simone Sandiford, my co-supervisor, Dr. Petria Facey, my lab colleagues, Nadia Curry, Simone Noble, Raheem Linyard. I would especially like to thank Ms. Shireen Ontley-Jones and her team for their donation of the Kitchetown field strain eggs, as well as to acknowledge the Global Infectious Disease Research Training Program, and special thanks to each and every other individual or entity listed on the slide here. These are, yeah.
Thank you very much, Mr. Mario Goldin. Let me see those who knew the scientific name of nutmeg before today. Okay, so I'm not the only one here. Okay, thank you very much, Mr. Goldin. Very interesting presentation, informative. We'll now go to Ms. Valicia Leach.
Good afternoon, everyone. Thank you very much for your warm welcoming. I want to thank the Ministry of Health and the National Health Research Conference to allow me to present on this research entitled The Antibacterial and Antifungal Analysis of Extracts from the Leaves of Malpighiaea glabra grown in Jamaica. I want to thank Dr. Tom Rodriguez and Dr. Roy Porter for supervising this presentation and research. And we will go straight in the presentation. Now, the objective of the study is to investigate the antibacterial and antifungal activities of extracts from the leaves of Malpighiaea glabra grown in Jamaica. According to the World Health Organization 2023, antimicrobial resistance, AMR, is contributing to a surge in diseases and deaths as pathogens evolve resistant to both existing and new medications, which makes it very hard to treat infections. Now, recent studies highlighted that herbal medications serves as some promising alternatives to conventional antimicrobials in combating antimicrobial resistance. Now, plants, they contain secondary metabolites or phytochemicals such as phenolic acids, tannins, flavonoids, quinones, coumarins that have been recognized for their promising antimicrobial properties. Now let us look at the plant Malpighiaea glabra. Now Malpighiaea glabra is also known as wild crepe myrtle or West Indian Barbados or Barbados cherry. It is a shrub or a small evergreen tree. Extensive research has focused on its fruits but little studies have investigated the antimicrobial properties of its leaves. Now, this study marks the first exploration of the antimicrobial and antifungal properties of leaves from Malpighiaea glabra grown in Jamaica. Now, for the methods overview, sample preparation, verified leaves of Malpighiaea glabra were dried at 70 degrees Celsius for 3 days and milled. For the extraction process, leaves were sequentially extracted with hexane, dichloromethane, and methanol. Extracts were then collected via gravity percolation and concentrated in a vacuum using a rotary evaporator, then stored. For the analysis, qualitative antimicrobial analysis was conducted using the agar well diffusion method, and active extracts were then further tested with broth or tube dilution assay to determine the minimum inhibitory concentration, which is MIC, and the minimum bactericidal concentration, which is MBC. Now, a total of 10 organisms were used in the experiment. We have our Staphylococcus aureus, Streptococcus pyogenes, Enterococcus faecalis, or Escherichia coli, Klebsiella pneumoniae, ATCC 1705 and 1706, Pseudomonas aeruginosa, methicillin-resistant Staphylococcus aureus, which is MRSA, and it was a clinical QC strain, Neisseria gonorrhoeae, a clinical QC strain, extended spectrum beta-lactamase producing Escherichia coli is a QC strain that was used, and for our fungal isolate, we use Candida albicans, also a QC strain. Now, let us look at the method. First, antimicrobial screening or well diffusion took place, where isolates, they were plated on Muller-Hinton agar with 6 mm holes. Plates were then held at 4 degrees Celsius for 1 hour, then incubated at 37 degrees Celsius for 24 hours for our bacterial isolates, and 48 hours for Neisseria gonorrhoeae in 5% carbon dioxide. This experiment was repeated thrice, and we used controls such as polymyxin B for our gram negatives and vancomycin for our gram positives. Now, organisms that showed activity were then further experiments on where we have done a tube dilution method, where in which these organisms would have shown a zone size of greater than 9 millimeters. Now, for the tube dilution, 1 ml of each extract was added to 1 ml of brain heart infusion broth to prepare doubling dilutions down to 0.0078 mg per ml for each solvent. 5 ml round bottle tubes were inoculated with a drop of microbial suspension, and it was then incubated for 24 hours and 48 hours for Neisseria gonorrhoeae. The MIC was then measured against growth and sterility controls, and the MBC was then recorded to determine the lowest inhibitory concentration. Now, this is a table showing the antibacterial and antifungal activity of Malpighiaea glabra leaf extract at controls 1 mg per ml as determined by the well diffusion method. And what was highlighted shows the zone size of Neisseria gonorrhoeae being the only organism that showed activity, and we further did the tube dilution for Neisseria gonorrhoeae. And here we can see with the methanol, it showed a zone size of 15 mm, for the DCM 11 mm, and for the hexane 10 mm. For the other rest of organisms, they showed little to no zone size. Now, table 2 shows the MBCs and the MICs of Malpighiaea glabra extracts when tested against Neisseria gonorrhoeae using the tube dilution assay. And for with our methanol extract, we can see where we had an MBC of 0.0156 mg per ml and an MIC of 0.0156 mg per ml. Now, with the DCM extract, the MBC of Neisseria gonorrhoeae showed 0.0078 mg per ml, and the MIC 0.03125 mg per ml. With the hexane, the MBC and the MIC was greater than 1 mg per ml. Now, according to the Centers for Disease Control and Prevention 2022, multi-drug resistant N. gonorrhoeae, which is Neisseria gonorrhoeae, is ranked as urgent and novel therapeutics are really needed to combat it. CDC also ranked this pathogen into various threat levels. And according to a research that was done, Varshni 2023, 82 million new cases of gonorrhea was seen among adolescents ages 15 to 49 years old. And Neisseria gonorrhoeae showed resistance to all forms of first-line treatments available in 2020. Now, this is a figure showing or depicting a urethral exudate containing Neisseria gonorrhoeae from a patient with gonococcal urethritis. Now, we can see that Neisseria appears as a typical intracellular pink diplococci, which is located within the cell. Some of the causes of Neisseria gonorrhoeae or gonorrhea is spread through sexual contact, including vaginal, penile, oral, or anal sex, and also through childbirth. Now, some of the common symptoms of Neisseria gonorrhoeae or gonorrhea. In men, we have penile discharge, burning or painful urination, and testicular swelling. Within women, we have vaginal discharge as well. We have burning or painful urination and bleeding between periods. Now, on the top right, we can see an image of a newborn that has contracted gonorrhea during childbirth. And this infant is diagnosed with ophthalmia neonatorium. And below the image of the infant, we can see the discharge coming from the male penile ear. Now, the methanol extract showed, in conclusion, it showed significant antimicrobial activity against Neisseria gonorrhoeae and may be possible in treating gonorrhea, developing antiseptics, disinfectants, moisturizers, and cleaners upon further investigations. While in vitro activity was shown in the experiment, this is just the preliminary phase. Further tests and clinical trials for future works must be done to demonstrate in vivo applicability. And this is the end of the presentation. Thank you.
Thank you, Ms. Leach, on that very interesting information on Barbados cherry. Let me see the hands of those who knew the scientific name of Barbados cherry before Ms. Leach. You know it as something else, right? You don't know it? Wow. What's that? Garden cherry. West Indies cherry. Okay. All right. Well, now we have the common scientific name, okay? So we'll now go to our question and answer section. Are there any questions in-house or online?
Questions? Yes. Thank you for your excellent presentation. And I will want to just quickly ask the two last presenters, highly commendable, and the presentation for Mr. Mario? Mario, yes, Mario. That was excellent, okay? So that insecticide, how can we get it?
Okay. So one of the things that we're looking into for the future work that have already started, that we're looking to formulate. So as everybody knows, oil and water, you put the oil on the water just floats on the surface. So we have two ways in mind to actually formulate. Because from the literature, how some persons they do encapsulate. That's one of the avenues. So, second avenue, I won't go into that one. That one.
You don't have to say if you don't want to
Yeah.
say. Thank you. Thank you. And the last presenter, thank you very much. Very excellent presentation. Now, the question is for the Neisseria gonorrhoeae and the extract that was utilized. You realize the extract was not effective against other known bacteria because there was no zone of inhibition. So what do you think make it more effective against the Neisseria gonorrhoeae?
For your question, I think the concentration of the extract would play a part in promoting the effectiveness of the experiment overall. So having a more higher dose of concentration is going to will allow the experiment.
All right, thank you.
One more in-house, and then we'll go to online. For Dawkins.
Thank you. I wondered if the study, when you looked at the findings, there an assessment of the efficacy of the insecticidal activity over time. Is it that does the efficacy decreases with time based on evaluation, or you have not yet assessed that?
Yes, so that is one of the things that that I found during the because for this research I had to go about. We found that as the time progressed, efficacy. So based on that, preliminary. Assumption or constitute volatile. That is actually one.
And the source of the nutmeg, I'm sorry, I can't say the scientific name. Was it all one place or?
Yes, so unfortunately, it was from one place, but it was from a local supplier. Pretty much. Tempted.
Yes, thank you, Ms. Leach, for that presentation. I know you are not a clinician, but I'm interested if we have an idea of the prevalence of Neisseria resistance in Jamaica. Is it something that is of public health concern right now, or is it still at a clinical level, just isolated cases?
Yes, it is concern clinical level, and there are cases, not accurate on the statistical data, but there are cases within Jamaica where the disease is prevalent among our people.
Yeah. Do you have any plans in your study, maybe postdoc, to think of the pupal stage? Because you know that's very important for vector prevention. You think you might be able to adjust the formulation to act at that stage of the growth cycle?
Yes. So Ideally, I would want to be able to identify something that's effective against all the different life stages. So moving forward, we plan to do a lot of research before we actually get to the formulation stage. And one of the things that we want to do is that we want to conduct gene expression studies to see if certain genes within the different developmental stages might account for the varying levels of activity. In addition to that, something not mentioned in the presentation is that the variation or difference activity between the larval stage and the pupal stage may have been due to the fact that against the larval stage, insecticides typically work through oral ingestion, whereas for the pupal stage, because the pupal stage is a non-feeding stage, the essential oil work through cuticle contact. So it's going to take, like I said, a lot of research to try to figure out what exactly is causing or accounts for the variation in activity, and maybe to see if maybe higher doses of the essential oil may produce a more significant against the pupal stage.
We'll now go to our online questions.
In light of Dr. Gordon's research, what can be put in place to reduce contamination in our public health facilities?
Thought I was done. No, so one of the recommendations that comes from this is that, particularly with regards to in relation to COVID-19, we have to get used to this new paradigm that we may need to be working more in PPE. So as part of our training, we need to be training people how to carry out what we normally do without PPE in PPE, so that we can not have this increased risk of contamination, which we suspect is part of the effect that we're seeing. So what it comes down to is putting in place training and quality improvement and assurance measures to make sure that we're not falling off from the minimum standard to reduce the risk of contamination.
And somebody else would like to hear the scientific name for nutmeg once more.
Okay, so the scientific name for nutmeg is Myristica fragrans Hoot.
Myristica fragrans Hoot. Got it. Right. Are there any more questions? So if there are no more questions, please give a round of applause to our 4 presenters for a job well done.
At this point, we want to thank Mrs. Ehika Menor in terms of moderating the session. It really was a suite of excellent presentations, and we want to thank her once again for taking the time to lead us through the session. So at this point in time, I would invite our moderator and our panelists. If you wish, you can exit the stage at this point. And so we have come to the close of day 1 in terms of our 15th anniversary. We have reached the close of our first day, believe it or not. Our conference began with a celebration of research excellence, and that excellence has continued throughout the day, beginning with our opening ceremony. And we have had many thought-provoking presentations under the themes of continuum of care, integrated service delivery, non-communicable diseases and aging, the Jamaica salt consumption study, and surveillance and laboratory studies. At the beginning of the event, we were remiss in not recognizing our moderators, and so we will have a chance to recognize them on ensuing conference days. The feedback that we have received online and in the room has been that the research presentations have been excellent. The onus is on us to ensure that the conversation does not end with this conference, but continues with discussions with our peers and trying to move the research forward so that it will inform policy and practice. As we prepare for tomorrow, we encourage persons to return. We have already seen that the fair is rich, and we encourage all participants to navigate the conference material. So what you're seeing is just a glimpse. We particularly encourage persons to view our poster presentations. Our poster presenters would have taken quite a lot of time and effort to prepare their posters, and so we're asking that you view those sessions. And remember that there is a leaderboard prize in terms of navigation of the conference webpage, including the poster page. So we encourage you to continue to join in terms of our health research conference, and we will see you again at 9 o'clock. Thank you.
What you girl? I feel stressed out. 2 months from my baby and a peer problem with breastfeeding. The baby not get enough milk like when I'm in at the hospital.
So why you never tell me?
I didn't even know. I now rest a peer problem with breastfeeding. People keep on telling me something to give the baby bush tea and say it good for him. Then my friend them tell me say if I breastfeed, my breast are gonna drop.
No go so. A 5 hour me breastfeed. I don't know my breast them. No make nobody stress you out. Because if you're stressed, you're not going to produce enough milk. I better ask your nurse or your doctor. Me hear the matter about breastfeeding support with our clinic. Then teach the young mothers how to breastfeed properly. And take care of the picnic. Then teach our family to, you know.
They're going to eat Friday when I go clinic.
And make sure you ask about the breastfeeding support group and join.
Thank you, Mommy. I don't know what me to do without you.
Breastfeeding is an act of love that bonds mothers and babies and provides mothers protection by lowering their risk of developing cervical and breast cancer. Breast is best. This is a message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.